It's a little after 1, and we'd planned to get started at 1. And I appreciate so much interest in this matter. The first thing the Appropriations Committee on Human Resources is going to hear from is the Veterans Affairs. We had asked in last year's budget, we put in some verbiage that we asked the veterans to see if we could perhaps get some funding from Medicaid and Medicare. We want to give the veterans the utmost and the very best care we can. And as everybody knows, money is tight, and we were just interested if there was any way that we could pull down some more federal dollars. And so that's the reason we put the wording in last year's budget, just to see if there's any possible way we could pull down more federal money, because you know we're so strapped and we want to give them the best care we can. And Commissioner Wheeler's not going to be here today. He has a previous commitment, but he does have people with veterans that are going to give us a presentation, and I'll turn it over to them right now. And thank you, and I want to thank you so much for you getting all your study committee together and giving us the report, and I think most of the people on this committee have reviewed the report.
Thank you, Chairman Nelson. Somebody can put my mic on.
Yeah.
The little green. I think it's working now. Thank you very much. It's good to be here and to give you a quick presentation on the report of the study group on the use of Medicaid and Medicare in Georgia State War Veterans homes. I've brought up a short presentation that I think will kind of focus what is in the report and hopefully may answer some of your questions. And if it doesn't and you have questions, why, we'll be more than happy to to take those. I have several members of the study group with us today. If you just raise your hands, folks, those of you who served on the group. Just by way of background, the War Veterans homes were established in the mid-50s and early 60s. We have two of them, one in Augusta, one in Milledgeville. There are two funding sources for the operation of these homes. The first is state appropriations, and the second is VA per diem payments. In Georgia, providing medical care to Georgia's war veterans rather than pensions to all returning war veterans regardless of need. That is what got the homes started back in the 50s. Returning veterans from World War II and Korea in a lot of states were given pensions across the board just because they served. Georgia elected at that time to provide a service to those who really had a need, and the decision that apparently was made at that time was to focus in on those war veterans who had a medical need in the form of nursing home care. And that's how the homes basically were opened up. Of course, the one in Milledgeville is an outgrowth of what is now Central State Hospital, and the one in Augusta is affiliated with, what are you calling yourselves now? The Georgia Health Sciences University. Thank you, Charles. The language Chairman Houston was referring to specifically said the General Assembly wanted us to examine the impact of certifying the nursing homes for Medicaid and Medicare for reimbursements for those medical services that are provided to our veteran patients. We formed a study group of 11 members, and that group basically worked to review facts, factors, findings, conclusions, recommendations, and ultimately the report that was put out on the 10th of January, which I believe all of you have access to. Some of the major findings: there is no authorization in state law today for the Department of Veterans Service to collect from veteran patients either directly or indirectly any kind of funding. And indirectly, we're referring here to Medicaid, Medicare, insurance, or any other third-party payer. That includes a large untapped VA medical benefit that the VA calls aid and attendance, which many of our veteran patients are eligible for, and many, not quite all of those that are eligible are receiving it, but many of them are. And the reason for some of them not being able to collect the cash benefit is because they're over income. But that money is out there. Every new patient who is admitted to either of our homes is given a counseling appointment at our field service office that is located at Augusta and the one at Milledgeville, and they apply for that aid and attendance benefit as part of that counseling visit. The use of Medicaid and Medicare programs would bring additional federal oversight, audits, inspections, payment issues, etc. In addition to the VA oversight that we currently have, the state oversight through the Office of Regulatory Services, and the voluntary oversight through the Joint Commission on Accreditation of Healthcare Organizations that are currently ongoing at both homes. Also, it would take up to 12 months to obtain Medicare and Medicaid certification, so the earliest we could implement collecting these funds would be in fiscal year 2013. There would be additional staffing required at the homes to support the collection process for going into these two programs, and we have currently projected that at a total of 5 positions between the two homes. The medical benefit of VA aid and attendance. All veteran patients of state veterans' homes are eligible for this VA benefit. Not all veteran patients are eligible for the cash benefit due to income restrictions. If the state of Georgia were able to collect a fee or a copayment, the amount of that collection would show as an expense on the VA income calculation and may make more veteran patients eligible for the cash benefit. Briefly, how that works is every year veterans who are receiving the ability to receive VA medical care have to fill out an expense form on how much money they have received and how much money they have spent on health care. Right now, if they are veteran patients at either of our homes, because we're not able to collect anything, their expense is zero. So whatever their income is coming in is shown as income. That includes if they are receiving the cash benefit for the aid and attendance. If we were able to collect that VA or an amount equal to the VA aid and attendance benefit, that would become a medical expense, and they could put it on the form and would lower the income that shows up on that form, which actually would probably make some of those folks who are eligible for the benefit but not able to collect the cash benefit now able to collect the cash benefit because their income has gone down. So they would be below the threshold for not receiving it, or at the threshold for receiving it, depending on how you want to look at it. Currently, the maximum aid and attendance benefit is around $658 a month, or $21.96 a day. The medical benefit of aid and attendance, again, right now would be collected at no cost, is a no cost from the VA money to the state because there are no administrative requirements associated with collecting it. There's no federal oversight, no audits, no inspections, no billing issues, no utilization review requirements. So none of that stuff that is required for participation in Medicaid and Medicare is tied in with collecting that VA aid and attendance benefit. And already we are being surveyed now by the VA because we are receiving the VA per diem payments. So they are actually our primary certifying agency. Veteran patients now receiving the cash VA benefit get to keep the monies, and they don't pay them to us. And that was really the intention of the federal law, was that those dollars be used to offset the cost of health care. If they go to a VA medical center or an outpatient clinic or a civilian provider of care where they have to pay, they can use those aid and attendance dollars as a source of funds to pay those bills. The major conclusions: Medicare and Medicaid are not the preferred avenue to obtain external funding for the operation of state veterans homes. The better means, we concluded, is to fund the operation of the homes in addition to the state appropriations and the VA per diem payments through giving us the authority to collect and get our hands on the aid and attendance monies. That's a VA benefits that is out there, and it's available. All we've got to do is have the legal authority to collect it. There would be a cost, just like there would be on the Medicare and Medicaid, but it's not as high. We're projecting right now that probably 2 people could handle that, because it's basically just receiving the benefit each month from each of the veteran patients and depositing it, and then that's basically the end of it. You don't have to do any reports, you don't have to do utilization review, none of that stuff. So the major recommendation is that the General Assembly pass legislation to give the Department of Veterans Service authority to establish, collect, and use a fee or co-payment from veteran patients of the state veterans homes, and that would allow us to get our hands on the aid and attendance benefit. The proposed legislation, which is attached to the report, would create a process for the department to establish and approve implementation of a fee or copay to be used. It would involve the commissioner and the Veterans Service Board in that process. If they determine state appropriations and the federal per diem payments are not sufficient to optimally operate the 2 homes, then they would make a determination to establish a fee or co-payment. All veteran patients would be treated equally with no differences associated with ability to pay, and that would kind of addressing the Medicaid issue in terms of health care for the poor. And I say that because we look at veterans as somebody who have served their country and have earned their place in a state veterans home, as opposed to an entitlement program such as Medicare or Medicaid. The number of veteran patients potentially eligible for Medicaid is projected to be only 40% of the total residents. Obviously, nobody's applied for it, and so there may be some more or less actually out there once actual applications would be put in. But our projection at this point in time is that there is not a large group of veteran patients who would be eligible for the Medicaid benefit. Medicare payments have to be directly related to a 3-day hospitalization. When the patient leaves the hospital, let's say the patient's in the nursing home for diabetes, and the patient has a heart attack. Goes in the hospital, is in the hospital 3 to 5 days, comes back to the nursing home. As long as the immediate care they are receiving post-hospitalization is related to that heart attack, VA will pay up to 100 days. The first 20 days, it's at 100%. The last 80 days, it's at 20%. I'm sorry, 80%, and the individual patient has to pay the 20%. So there's a 20% copay for the last 80 days. Now, that's the maximum. If the care of that patient is determined that they've met all of the goals that they need to meet in terms of the treatment for that heart attack, and the only reason they need to stay in the nursing home is because they have diabetes, then the Medicare payments are going to cease. So if that happens at day 20 or day 30 or day 100, whenever that happens, then the Medicare payments would stop. Now, Also with the Medicare, there is a 60-day waiting period between the time the Medicare payments stop and you can have another qualifying hospital event. So you can have multiple 100-day periods, but you got to have a 60-day waiting period. We believe there should be sufficient funds available from the collection of the VA aid and attendance benefit that Medicaid and Medicare funds would not be needed. Being that state veterans' homes are nursing homes, we don't believe necessarily means that they need to participate in Medicare and Medicaid programs, especially if there are other federal funds available. And I think to a certain extent that goes back to Chairman Houston's introductory comment. You know, we're looking for additional money, and we feel like getting it from the VA is the better place to go. Collection of a nominal fee or co-payment from veteran patients of state veterans' homes would put a minimal financial burden on veterans compared to the amount of the burden associated with Medicaid and Medicare programs. And I've presented an example here on this next slide. Right now, as I mentioned earlier, the per diem rate for aid and attendance is $21.96. Using the projected census at the two homes this year, 170 at Augusta and 235 for Milledgeville, we could generate something in the neighborhood of $3.2 million in theory. That would allow us to increase the census at Augusta from 170 to 185. And actually, the numbers would generate 213 patients, but they only have a chassis over there that'll take 185. So that's where, as you look at that example there, that 28 comes from. And so what we're saying on the example is that we would take those 28, the dollars associated with those 28 patients, put them over to Milledgeville, and that would allow the Milledgeville census to rise to 326. Yeah. So the goal of increasing census is something that's very doable.
Mm-hmm. I think we have a few questions.
Okay, that's fine.
And I'm going to ask my questions first, and then I think some of the other committee has a question. Did the study committee, did y'all involve the Department of Community Health in this study, the Medicaid Division of Department of Community Health?
We, not directly, but one of our study committee members was one of the budget analysts from OPB, who is a health policy trained person and is in fact the OPB analyst for the Medicaid program. And so she worked with us as part of the group.
Okay. How many veterans are currently in community facilities in Georgia? And not in the veterans' homes.
Right.
How many do we have out in community settings?
I got that number the other day, and unfortunately I didn't bring it with me. We queried the Southeast network of the VA to find out what that number was. And there's about 122 that are in community nursing homes in the state of Georgia that are under contract to the VA.
But there are only 122 veterans in nursing homes in Georgia that aren't,
that are VA, that are in contract beds.
In contract beds,
right.
Okay.
Yeah, the nursing home beds at the VA medical centers are all short-term nursing home beds. Basically, the longest period of time that they want to keep a patient is 90 days.
What do you contract those beds out to your private community facilities?
You mean what's the cost of them? They didn't ask. They didn't give me that figure, and
all right.
and that is a VA responsibility.
Okay.
So
all right. The next thing I wanted to ask you, or just sort of, you said that Medicare was an entitlement program.
Well, a lot of people consider it to be an entitlement program.
I'm on Medicare.
So am I, ma'am.
And I thought I paid in for that. I thought I paid money to be a part of Medicare. I thought I paid.
Yes, we both did. Yes.
Okay. Thank you, sir. I just wanted to clear that up. Representative Sassler.
There we go. Have to hold it. Okay. Again, appreciate you coming today and laying this out for us. This kind of gets to the heart of some of the issues we've been talking about in previous hearings, and I really appreciate your lay down on this. Question I've got about if, as part of the decision to accept Medicaid, Medicare, isn't it true that if we were to accept those dollars at VA homes, that there'd be a recovery on the back end of that assets of people would be subject to be taken, whereas there's no requirement to take assets in people's estate under a VA program?
On the Medicaid program, that is correct. Okay. And you're correct. On the VA side, there is no requirement for anything to be repaid to the government at all.
So as you weigh out these decisions and you're stacking up sort of the benefits on the right and the sort of the shortfalls of any program on the left, if you're in the consideration of Medicaid, Medicare, one of the detriments of doing that would be the recovery of assets from an estate, from the veteran's perspective at least.
Absolutely, sir. That's one of the main concerns that we have, yes.
You were very clear about the administrative overhead. You think it would be about 5 full-time equivalent staffers to kind of manage that whole process. Would there be any substantive changes to level of staffing, level of support, those kinds of things, from more of a medical service provider side that would be required by Medicaid, Medicare that's not required by the VA?
I'm being told by my community nursing home expert from Pruitt, no.
Okay. So there would be no additional requirement on that end.
The staffing levels that we are requiring now under the contract that we have with Pruitt and the requirement that the state has, they meet the Medicare requirements of 2.5 nursing hours per patient day. Okay. So we meet that requirement. So that as the patient load would rise, we would start bringing more staff in so that we maintain at least a 2.5 ratio of nursing hours per patient day.
Okay. Yeah, I see your census here going from roughly 405 to 511 as you projected the slide. I'm assuming there's going to be some efficiencies. I mean, if you're increasing your population by 25% or so, the overhead of the program in general on a unitized basis is going to go down, and you're going to be more efficient in doing what you do, I assume.
Yes, sir.
Madam Chair, one more question if I could. So just trying to unpack this, with the $21 addition that we're contemplating here in funding, and I want to use my terms properly. Forgive me.
And let me just interject. That is just an example figure. Okay.
But with the introduction of the aid and attendance, right, are there any additional requirements that come with that at all? You said there are.
No, sir.
If there are none, is there a reason we've not collected that in the past?
There is no provision in state law for us to do so, and that's been it. Again, going back to the history of when the homes were established back in the 50s and 60s, the legislation that established them set up the payment mechanism to be state appropriations and VA funding, and that was all that was provided.
So in essence, the law in the Georgia Code that governs this really hasn't changed, and the aid and assistance program has come in later, and we just have not done anything legislatively to pick those dollars up and bring them in.
In essence, that's correct, yes. And I say it that way because I'm not exactly sure when the VA aid and attendance program was actually brought on board. But when it was initially funded, those were the two primary sources of funding, and there hasn't been a change since those homes were established.
And Madam Chair, briefly, and again, not to shoot the messenger, I mean, is there any reason that the department hasn't made this recommendation in the past? Is this something that's just not gotten the attention of your leadership, our committee?
I think our leadership and historically the leadership of the General Assembly has been that we are providing this benefit to the veterans of Georgia. It's a no-cost benefit, and we're very proud that we're the only state in the nation that has a no-cost nursing home program for our veterans.
But the aid and attendance dollars wouldn't necessarily require a contribution from the veteran, would it?
That's correct. They do not.
Now, with these dollars coming in, I know you talked about was it $150? What's the total cost for care per day for your clients? For your
at Augusta, it's about $85 a day, and in Milledgeville, it's $81.71, and that's on the state side.
Sure.
Take those two numbers times 2, multiply them, and that's the total cost of care per day.
So using these generic numbers, I know they're just models, they're not specific, but taking a cost from $85 a day, adding $21 of new money into this, gets you down to somewhere in the 60s. In the study and within your leadership of the $60 per day left, do you have any expectation of what percentage of that would be shared by the veteran and what percentage of that might still be state funded? Okay.
Well, actually, it would be still on the state side. It would be the full $60-some-odd. The VA is going to pay 50% of the cost of care, whatever that cost of care is, and that's something that's determined basically on a monthly basis on a report that we have to submit to the VA, and. So whatever the total cost of care is divided by 2, and the VA is going to send us a check for that. So if the state side is made up of state appropriations and collecting aid and attendance, or the value of the aid and attendance, then that would be the state side. So it's still, the VA is still going to pay 50% of the total.
Thank you. I think Representative Hurd.
Thank you. I want to kind of follow up with that line of the previous line of questioning. Isn't it also true, though, if the veteran sets up a Miller Trust, that he would not have to be concerned about the asset recovery?
I'm going to have to defer because I'm not that familiar with the Miller Trust, but that is correct, yes.
So basically, in doing so, there would not be any liabilities for that veteran's or
if that trust was set up, then
the trust was set up.
Right, that's correct. Yes.
Okay. Thank you, sir.
Representative Hall.
Thank you. It's very, very helpful. I believe you told us last week that there were, of the 700,000 veterans in Georgia, that y'all had estimated 500,000 would probably be eligible for admission to the Milledgeville or Augusta facility. Am I remembering that correctly?
Yeah, because they are, and the difference was that those 500,000 have served during a period of war.
And y'all define the Cold War as war.
That's in state law, yes, ma'am. And
in relation to the number of 121 veterans that are in other nursing homes, you really are referring to in federal VA nursing homes. You're not referring to a number in the other more general nursing home population. Wouldn't it be fair to assume that they're...
Well, they actually are in the community nursing home population. They are contracted beds.
Okay.
The VA has gone out to the nursing home in Augusta and said, we'd like to contract 2 beds with you to take care of veterans, and they make an agreement, and then 2 veterans go in there and occupy those beds.
But your number does not reflect the number of eligible veterans that are in nursing homes in general in Georgia.
That's correct.
You really don't know how many of the 500,000 eligible veterans are currently in a nursing home that is receiving some blended funding of Medicaid and other
That's
provisions.
true.
So we're treating veterans differently in Georgia.
Yes, ma'am.
And some are all state paid and some are blended federal paid. And the policy consideration for that is what I'm grappling with right now. I'm aware that in other states there's a significant additional federal match to state matches for construction and opening of nursing homes and upgrades of nursing homes. Do you have any applications at this for that particular federal money for expansion of veterans nursing homes that have that federal match?
We actually have two projects right now that are ongoing at the Milledgeville home. They're both electrical and life safety upgrades in two of the buildings down there.
But you don't have any applications in for new nursing homes?
Not for new nursing homes, no.
And that would be a more blended federal model?
Well, it would be the model that it would be the state veterans home model.
When you told us last week that you didn't think many of the patients in the existing nursing homes would be Medicaid eligible, I guess it's a matter of perspective. I think 40% Medicaid eligible is fairly high. Are you thinking that's a low number?
Well, based on the numbers that we see, I'm thinking it's low, and I guess it's because it's less than 50%. And a lot of people have said to me in other conversations I've had that, well, you must have a lot of people who are Medicaid eligible, and we don't.
But you have 40%.
40%, yes.
Okay. And then it is a perspective. I think that's a significant number that in other nursing homes down the street are receiving a significant federal Medicaid funding for the same quality care. So, just speak for myself, Madam Chairman. I don't speak for anybody else.
Thank you. I have other questions. Other questions. Thank you, and thank you so much for coming.
Okay.
And I want to ask, on the project that you currently got going, are you getting any federal money on the rewiring and?
Yes.
Okay.
65% of the funding on both of those projects is federal dollars.
Mm-hmm. Thank you. Thank you so much for the job you do.
Thank you.
Well, we're a little early, aren't we? We'll take about a 5-minute break.
I just want to put a face with a name.
Okay.
Here, Luigi Mancini.
Okay.
I'm going to make some comments.
All right. Thank you. Thank you so much. Thank you. If everybody could have a seat, and could we close the doors in the back, please? No, we're going to have public comment first. I did. Thank you. I appreciate everybody coming. This is, if you probably know, this is a House Appropriations Department of Human Resources Division of it. And there's been lots of concerns about some of the ratifications of the Justice Department agreement that we made. And a lot of the public has been have some problems and some things they want to discuss with us. And we thought this would be a good time that the Appropriations Committee could listen to your concerns and see if we're putting money in the right place and where we need to be putting the money, that if they'll let us direct it where we want it to go. Not they, I'm talking about the Justice Department, and try to see if that's where it's serving the most people. And we have a lot of people that have signed up. I think we have about 22 people that have signed up. And if you could limit your comments to 3 to 5 minutes, maybe 5 minutes at the most, because everybody wants to talk. And so if you could just sort of, and I'll call out 5 people so you can be in line to get up there, the first 5 people that signed up. Terry Norris is first, Bill Massey, Pat Nobby, Josh Norris. Those are the first 4. And then Greg Kirk. And if you'll state who you are, where you're from, and just tell us what you would like to discuss with the committee.
Yes, ma'am. I'm Bill Massey. I'm bumping ahead of Terry Norris. I'm the sheriff of Baldwin County. I'm also the director of the Baldwin County Mental Health Hospital, known as the Baldwin County Jail. And I'd like to speak with y'all about mental health issues in our jail and in law enforcement in our community. I appreciate meeting with y'all today. And last week I got a call from someone in Atlanta and said that people in Atlanta were going to talk about the Baldwin County Jail and the Oconee Regional Hospital, so I'm glad I had the opportunity to come because I didn't know anybody was going to discuss our lives. I know everyone in here has a different opinion on the truce that we just signed with the Justice Department. I've read it 4 times, and it basically, to me, is a developmental disabilities agreement. To be real, not being smart with the crowd, especially with your committee, the sheriffs of the state, we don't even know there are developmental disabilities. We don't have issues with that in our community. If we do it, it's very seldom. What we're really overwhelmed with are mental health issues. In fact, it's so bad in the Baldwin County Jail that Baldwin County Jail and the Bibb County Jail probably overwhelm the Powell building. The state sent a psychiatrist to the Baldwin County Jail to meet with our inmates purely because they wanted to medicate them, keep them in the jail because they couldn't handle all the patients coming out of the Baldwin County Jail. In the last 12 months, we've had 291 inmates that have been treated by a psychiatrist. Now, this is not our psychiatrist. This is a state psychiatrist. We don't have the money for a psychiatrist. And if the state quit servicing these 291, I don't know how many we would end up transporting because we only transported 7 out of the Baldwin County Jail to somewhere, to a hospital, or to be serviced because of a 1013. Had we not treated them in-house, I don't know what we've done. On the outside of that, getting away from inmates in our jail just purely from what we call civil commitments or 1013s in our community. In the last 6 months, from July to December, we transported or handled 232 what we call 10107s or transports, and most of these were from mental health issues. It's a tremendous burden. Now, I know that I'm not going to do a day-to-day dialogue of what happens, but I'm going to give y'all a sampling of a small sheriff's office like we have in Baldwin County. And we have a very good, I'm going to say, vendor that helps us. We have River's Edge. They do a phenomenal job with us. If they didn't, I don't know what we would do. But this is January of this year. On January the 5th, we took one to Stockbridge, we took one to Augusta, we took one to River's Edge in Macon. On the 6th, we went back to River's Edge in Macon, we took one to Coliseum in Macon, and then we took another one to Macon. On the 11th, we took one to Coliseum, we took one to Savannah, Georgia. On the 13th, we made 2 trips taking individuals to Augusta. Then on the 14th, we went back to Macon. On the 15th, we took one to Dublin. Then we took one to the Phoenix House in Warner Robins. On the 18th, we had to pick up in Augusta. And then on the 20th and the 21st, on both those days, we took people in civil commitments to Augusta. On the 25th, we went to Dublin. We went to Augusta. We went back to Macon with one, and then we went back to Augusta with another one, and then we went back to Macon. The 25th was really our favorite day because we took one to Villa Rica, and then we took one to Augusta, and then we took another one to Augusta. In those days, we had 51 inmates seen by a physician in the Baldwin County Jail. Now, our in-house physician was able to continue medication on 20 of them. 31 of them had to be seen by the psychiatrist. And so I'm just, that's one county. And this is a situation that we're in. We look up, and I understand money is in terrible supply now, especially in Baldwin County. They've closed so many state agencies in Baldwin County. When somebody comes in our county with a backhoe, I send people to guard the veteran cemetery. I'm scared they're going to dig something up and leave with it. I know it's bad, but we're closing hospitals. And in addition to the 9,000 mental patients in the 147 county jails, 200 of those are what we call forensic patients that have been, by court sentence, remanded to the custody of the state of Georgia. Now, we have them in the Baldwin County jails. That's the Adons of the world that committed the murder in the DeKalb County jail and then killed someone else while he was in the Peyton Cook building in Milledgeville. So we're overwhelmed with them. I realize people are shifting money, and transporting is expensive for sheriffs, but that's our job. We don't mind transporting them, but we have to have clinical bed space. We have to have a place to put these people. Now, I realize in this truce that was signed, we've got deadlines, and something's going to happen in 12, and something's going to happen in 14, and something's going to happen in 15. But I'm going to tell y'all, the sheriffs of this state, we're not looking to 2015. We're looking to tomorrow, because tomorrow we're going to end up transporting a lot of people. Thank you.
Any questions? Manning.
Yes, sir.
No, ma'am. It's when they are officially given a 1013 form, we have to transport them to a facility. But a lot of these, we respond to families and we respond to the community, and we end up taking them not only to the hospital when the 1013 is signed, but we also end up taking a lot of them for families to the hospitals at the beginning of the situation.
So of these numbers that you just reiterated, are how many of those are children?
I would say very few of these are children. That's a whole other issue you don't even want to get into on juveniles. No, most of these are adults. I don't remember us having but very few issues with children that we have to transport with the 1013.
Okay. When you say children, are you including your 18 and overs?
No, ma'am. With the sheriffs and with law enforcement in Georgia, at the age of 17, right, they're of age. They're not juveniles, and we don't treat them as such.
Okay. Thank you.
Yes, ma'am.
Any other questions? Thank you, and thank you so much for coming.
We flip-flop, Madam Chair.
Okay, I thought you looked familiar.
Yes, ma'am. Madam Chair, members of the committee, my name is Terry Norris. I'm the Executive Director of the Georgia Sheriff's Association. I've had the pleasure of working with many of you for many years, probably more than we want to admit. I'm really here for three groups today, as I was thinking. First of all, I want to say this. It's unusual to be in a room of this many people that all really have the same mission in mind. And the mission is to better treat the mentally ill in our state. We all have different functions, different roles, but the common goal is these folks need help, and we're going to do our part, and I know these folks will too. But I'm basically here for three groups. I'm here for all the folks out there that suffer from mental illness. I'm here for those Georgians who pay property taxes. And I'm here for the sheriffs and the deputy sheriffs. There's probably, 12,000 when you look at all of them, sheriffs, deputy sheriffs, and jailers. I wanted just to talk to you just a minute about the most recent information I have, and it's old. It's 09 information. We provided a little survey, a little questionnaire to our sheriffs. 126 sheriffs responded to this questionnaire. I've sent a revised questionnaire of this similar type data or questions to the sheriffs at the beginning of this year. I hope to have information on 2010 in the next week or two, so I might be able to update some of these figures. But I just want to go over a few highlights. First of all, I think it's important. We're all taxpayers in this state. We pay for county jails. We pay for what the budget that's required for the office of sheriff. So we're footing the bill on everything we're talking about from our perspective. In the 09 reporting period, as I said, I had 126 sheriffs respond to a few questions, just a couple of them. Inmate medical care in jails. Those 126 sheriffs reported in 09, they spent $105 million on medical care for inmates. Right now there's about 42,000 inmates in the county jails. There's only about 52,000 There is about 52,000 in the prison system. So we as local taxpayers are paying the cost of a lot of inmate costs. So that was $105 million in medical. In that same period, the mental health meds, these sheriffs reported $7.8 million. Now, that's mental health meds in the jail setting. Again, we're paying for it. Let's move to the transport side, mental health transports. Mental health transports occur really in three ways. They occur most notably in what's considered to be a 1013. It's a form that's created by the state. A physician can sign that form, and that person of which that form was signed on will be transported for an involuntary commitment for a mental health evaluation. That person may be deemed or possibly deemed a threat to himself or others. Sheriffs do those transports. There's another way. It's basically the same transport, but it's also through judicial order. A probate judge can do the same thing. It's not a 1013, it's an order. And then there is another form, a 2013, which is a state form that deals with substance abuse. So how many transports are done? Now, these are civil commitment transports. These are not necessarily somebody in the jail. They could be, but not necessarily in the jail. The 09 data showed us, out of 126 counties, that there were 14,312 transports on 1013 forms. There were another 3,741 judicial ordered transports for over 18,000 transports in 09. Now that doesn't mean 18,000 people, because as you all know, we transport the same people a lot. The cost of these transports to counties was about $1.79 million for that year. As for the juveniles, the report I had that year, there were about 840 juveniles transported during that period. That's some general things. Bill Massey, Sheriff in Baldwin County, former president of the Georgia Sheriff Association, former legislative chair, he's our mental health guru. He's everywhere he can be. But Bill Massey talked to you a little bit about what's happening in Baldwin County, which is a snapshot. I hope to have a bigger and better information on 10 soon. Just a second on what I perceive and what we've heard about the plan to close the facility in Rome. And I think there's a very good idea brewing, and that is maybe to contract with local medical facilities across North Georgia. And if that's done, it would possibly could cut down on the amount of time and the distance that sheriffs make these transports. There'd be multiple locations theoretically. You could go there, you could do that, you could possibly get back to the county. You know, a plan's a thought. A plan is a thought. And I hope that thought works. But we've heard of a lot of plans over the years that have not worked. If this plan's to work, though, in our opinion, there's got to be something built in for security. Because most of these facilities, I would guess, that we're talking about do not have secure beds. So when that sheriff's deputy shows up at that hospital that 15, 20 beds are contracted with, that hospital is very likely to say, you got to stay with him and guard him. If the plan is going to work in our eyes, there's got to be a provision for some funds to pay off-duty deputy sheriffs to sit at that hospital and provide that security. Now, I'm not saying off-duty police officers. I'm saying off-duty deputy sheriffs. And rightfully so. Those are the people that's dealing with the mental health issue as much as anybody in the state. So those are my comments. Thank you for the opportunity. And again, I truly believe that everybody in this room has the same mission. And I don't think there's any enemies in this room, to be honest with you. So thank you.
For coming. Pat.
Good afternoon, Madam Chair and members of the committee. Thanks for the opportunity to speak. And that's kind of a hard act to follow because I'm with the Georgia Council on Developmental Disabilities. But in terms of the settlement agreement and some of the issues that we've been hearing about this week about the closure of the Rome Hospital, it's really about thought and planning and community development for all the populations that are going to be affected. And I would say that the primary activity that needs to occur in the 5 years that we're going to be working on the settlement agreement is successfully supporting individuals with mental illness and developmental disabilities to move from state hospitals to their own homes or family homes in the community of their choice. The main task is not closing the bricks and mortar. The task is about the people, not about the buildings. And I'm just going to focus on three things that we've been talking about in the last couple of weeks that need to occur prior to making some of these transitions. First is provider development. We have over, and I'm just talking about the DD population right now because that's my area. We have over a dozen counties in Georgia with no providers. We have hundreds of people with disabilities living more than 10 miles from a provider. In many areas of the state, people only have one choice of provider. There are not enough family support, respite, or employment services available for the folks that we're going to be helping to transition. There aren't enough options for residential support. A support system for people who fall into crisis because of the loss of their caregiver is not in place. One of the statistics that you'll see in a lot of our documentation is that there are 19,000 people with disabilities living with caregivers over the age of 64. So this is a tsunami that the state is not prepared to deal with. In the FY11 budget, there are no community waivers. There are no waivers for people in the community who may lose a caregiver because they fall and break a hip or have a heart attack or a stroke. And in the 2012 budget, there are only 100 community waivers to be budgeted. There are 5,700 people on the waiting list. And I know every legislator in this building received a large postcard from the DD Council that told you how many people in your county needed respite, family support, residential support. When you break it down by county, it doesn't look like a lot of people, but the list is about 5,700. Older individuals with disabilities that are living with aging caregivers are at enormous risk for ending up in nursing homes because of the loss of a caregiver. So we need a better network of, good quality providers across the state. The second issue that we're thinking a lot about is workforce development. State hospitals employ hundreds of people. 6 months prior to transitioning a hospital, workers in the hospital should be asked if they want to work in a community setting. Many of them have long-term relationships with the individuals they've supported in the hospital, and particularly with DD, they have a very specific skill set, and they have long-term relationships.
I hate to interrupt you, but could you tell us what you think we need to do? That's what we want to know.
Yeah, I'm going to tell you in a minute what I think you need.
Okay, well, you don't have very many minutes.
Okay, well, workforce development is another thing, and I think we need to figure out how to retool the hospital workforce to work in the community, and there's lots of states that have done this, and there are ways to do that, even looking at wages and benefits and how those things can transfer. The third thing is conversations. I think we need to actually sit down with people in these communities, the stakeholders, the sheriffs, the businesses, families, the people who are transitioning, and the staff, and problem solve together and get some support in the community before we make a decision that things have to happen. I think the task is about opening the doors in the communities for people and not just about closing buildings. And the DD Council has a network across the state. We have relationships in a lot of these communities, and we have offered our help to the department and to the legislature.
Well, I have to say this, that DDs have a great support group throughout the state, and I think that the transition for DDs would be so much smoother because of the support system they have. How do you think the transition has gone when they closed Milledgeville for DDs?
Well, there are still people with developmental disabilities in the Milledgeville facility. It was more mental health that transitioned from Milledgeville.
You have not
We have moved people from every state hospital, but I don't think we've only closed one DD wing in the state hospitals in Savannah, correct?
So there are still people in Milledgeville with developmental disabilities.
We do know how to do that very well. When we do move people, that happens very well. It's what we're concerned about is the people in community, that there's no waivers available for them. There are no even emergency waivers available for them. So if somebody's parent dies, they're effectively homeless. They'll end up in a nursing home. Some other relative has to step in because the division has no capacity to provide immediate services for those folks.
Is part of that in the settlement that it should be in place, or?
The settlement includes family support, which would help. Money for crisis, respite, and nursing, which will help. But in the FY11, there's no requirement for community waivers, and in 2012, the requirement is 100 community waivers in the settlement, which is a very low floor.
I agree. We've got some questions. If we could limit it just to 2 questions, please. No offense.
No offense taken, Madam Chair. You talked about there being counties where there are no providers, and there's, in your opinion, a shortage of providers. First of 2 questions. How easy is it, in your opinion, for caregivers, groups of individuals who are qualified to become an actual provider, to be able to expand those services beyond where the existing providers would have an interest in going?
I don't know if I can answer how easy it is. I know there are people willing to do that work. I think the state office and the regional offices need to make that communication, they need to facilitate that communication and support that communication. If I was the director of the Division of DD, I'd want more staff to help me do that. I think that's the biggest challenge that we face is provider development, because you have to have a door for those people to come into and say, I'm willing to do the work, but you also have to vet them for quality, skill, fiscal responsibility. I mean, we want good providers online for folks, for mental health and for DD.
Madam Chair, if I could tell a real quick example from my district as a setup for my question. In North Cobb County, there's a caregiver that's with, I won't name the provider, but it's under a provider. She's providing care to 3 young men, late 20s, early 30s. These young men have been with her for over 15 years, 14, 15 years. And it was her desire to move to a different provider, to stay the caregiver for these young men, but things weren't working out between her and her provider. She was considering going out and becoming a provider herself. And the non-compete clause she has with her existing provider prevent her from establishing herself as a provider and having the young men that she works with go with her. Those 3 young men would be required to stay with the old provider that she's leaving, and the caregivers and providers can't stay together if there's a change. I see that, I understand non-compete clauses, but I see that as a real problem in the system that's perhaps an impediment to expanding providers. And I would ask you to comment on that if you've seen that before, and if this is an issue that we might need to consider statewide.
Well, DD Council is not a provider, and that's not my area of expertise, but that sounds familiar, and that's, I think, a policy issue that can be changed. I think what we're trying to set up for people with disabilities is that they are in their own home or their family's home, and they own the home. So if a provider changes, they don't have to move. They are not the ones in jeopardy. They can, have staff come in and work for them. And it's a difficult thing to wrap your minds around, because I know probably everybody in this room is thinking of a person that couldn't possibly live in their own home. But I'm also a mom. I have a 26-year-old daughter with Down syndrome who on paper has an IQ of 50. She's living successfully in Athens in her own home with support. So I think we know how to do it well. There's always going to be challenges. But I think the goal is to have people in the home that they can call their own, and the provider or the system or the administrative is not going to jeopardize their residents. So those are conversations we need to have. Those are conversations we need to have in advance of closing a hospital.
Thank you, and thank you so much. And we're going to
thank you very much for your time. I appreciate it.
And please, wait. I think we've got another question. I'm sorry, Pat.
It's okay.
Representative Manning.
Pat, you indicated that there were only 100 community waivers for the budget of 2012. Can you tell me what number you think there ought to be? Because according to the 20...
yes, we would like 1,500 waivers, if you're asking. 5 years ago, Unlock the Waiting List got a multi-year funding plan resolution, which you're aware of. And the purpose of that was to sort of project out over 5 years how many waivers we'd need in the system to get the waiting list down to a reasonable pace, which is the Olmsted language. And it was 1,000, and then 1,500, and then 2,500 in 2010. We didn't get 2,500 in 2010. We didn't get any last year, just 150 to transition from state hospitals. So we're stalled as far as community waivers go.
Do we still have some of the Katie Beckett and the other federal waivers that were out there at one point in time?
Yeah, there are still families on Katie Beckett, but that is not the same as what we need to support these folks. It's a different. Those are children under 21 or under 18.
I realize that, but in the world of worlds, I was just trying to figure it out.
I know.
Okay.
Well, I mean, we look for every possible source that we can support people. We're really happy to see the family support dollars in the settlement agreement. That's flexible money. It does allow us to keep some people out of crisis.
Thank you.
Thank you.
Thank you for asking.
Thank you for what you do. Greg, Kurt. I'm sorry, I missed you, Josh. And if we could just sort of limit our things, we've got a long time.
I appreciate that, Madam Chair. Good afternoon. I'm Josh Norris. I'm the legal director at the Georgia Advocacy Office. And we had the privilege in this U.S. v. Georgia case of being an amici, and that's legalese for a friend of the court. The judge granted us the status of being involved in the negotiations and trying to figure out a solution or the beginning of a solution to a larger problem that Georgia has around services for people with developmental disabilities and mental illness. And usually I'm the bearer of bad news and doom and gloom, but actually I really want to strike a note of optimism today. I know that the announcement of the closing in Rome and that other things have caused a lot of people to get very anxious about what's about to happen. But I want to remind everybody that we're in the beginning of a marathon. The negotiations took us forever. And working through this agreement and all the things that we potentially could accomplish, it's going to take a whole lot of hard work. And I don't want anybody to feel as though that is something that is just on the department. It's on all of us. And at the end, it's something we've got to really sort of remind ourselves periodically. But I ran competitively when I was in high school and college. And, whenever I was running a race, I had a plan for my race. I had a plan as to how I was going to start off, what my pace was going to be, how I wanted to finish. So I tended to be one of those folks. I like to establish an easy pace and have a kick at the end. There were other folks that raced against me. They liked to get out to that fast start. I had to make sure I adjusted my race accordingly. And I think that the big thing here is we've got to have a plan. I believe, and this is, I think, something that Terry Norris indicated, and I want to echo, is that we're all here in an attempt to try and work together to solve this problem. We all want this to succeed. We are all invested in our success. Because if we don't, the implications are pretty drastic. So the real question, I think, is what race are we running? And it was funny, when I came in, I was talking to Representative Neal, and we were talking about the fact that, his concern was that we were going to get too caught up in deadlines and too caught up in facilities and buildings and things like that, as opposed to really thinking through what are the implications for people and what's the bottom line here? What are we actually trying to achieve? And I think that as long as we keep sort of these basic human needs in focus, we're going to be okay. And the agreement to a large extent reflects this, okay? When we were talking about how to address this problem, housing, for example, became a huge issue. It is a huge issue. And it's going to continue to be a struggle for us, but we've got to start putting the planning in place, figuring out how we're going to use the existing resources and maximize what we could bring into the state to address this problem. Because if you don't have safe, permanent housing, if you're constantly subject to disruption, our chances of success are not good.
I think we've got Mayor Margaret.
Thank you, Madam Chair. I'm going to ask my questions to Josh because Please. I know him well and I know how close he's been to this process. This is probably my fault that I haven't done enough work on this, but I can't figure out how 780 employees and 70-something buildings at Batty, that historical facility is not going to be used for something. Mm-hmm. I can't figure out, you have a very helpful philosophical framework, but what planning has existed where that campus is going to all of a sudden become vacant? What services can be provided? What services can be transferred in a new model at Rome? Do you know anything about that? And secondly, what is 18,000 transports that the sheriff's office have to do every year? How is that going to be hurt or helped by the settlement agreement?
Okay. As far as institutions go, when they are built and when they exist, we will fill them. That's just, in my experience, that's the way that works.
But if we close it in the next 6 months, what happens to those buildings?
Well, you can do all kinds of interesting things.
What plan has been made?
Right.
And are the bonds still being paid for the building at that place?
I don't know the answer to that question, unfortunately. That would be, I think, something directed at either the Department of Behavioral Health or some other agencies that deals with property, state's property. But other states have torn these places down. They've turned them into condominiums. I mean, there have been, rather than thinking about it simply as a piece of land that could only be a place where we serve people with disabilities, we can completely reimagine what we're going to do with that property.
But you're confirming for me that you don't know of a plan, and if anybody would know of a plan, it might be you.
Well, I don't know of a plan.
Okay. Does Medicaid allow in-state facilities and outpatient facilities to exist in the same facility?
That's a good question. It's a hard question. I know that there are a lot of restrictions around how inpatient facilities can do outpatient services. I don't know specifically how that works in the mental health context or developmental disabilities, but state of the art is that rather than thinking about places where people go, and the way this settlement is designed is that we look at where people are. I was talking about safe and permanent housing. If we have safe and permanent housing, we bring services to them to support the stability of the housing, to support their having meaningful things to do with their day, preferably employment, that we support them in that. Because as with every other human being, when our housing is stable and we've got a work-ordered day and something productive to do, we do real well. And to the extent that what we're trying to do, and I think the vision behind a lot of the provisions in the agreement, were to take that kind of knowledge and try and fashion services and systems that actually speak to that actually support people where they live.
The fact that I agree with you philosophically doesn't help me understand what's going to happen in a very pragmatic way.
Right. Well, and I agree with you in the sense that there is a lot to be filled in. There's a lot of detail here. And there's got to be, and what I appreciate about this committee holding this hearing today is the fact that I hope this is the first of many more discussions, not necessarily here at the legislature, but around Georgia, around these issues, so that in Rome and throughout Region 1 in the northern part of the state, we could start bringing together, people themselves caught in this system, the sheriffs, the medical community, hospitals, and other stakeholders to actually have an honest conversation about what are our strengths right now? What do we actually have in this community that could help us to grapple with this? What are our needs? And stake that out explicitly and have a conversation about that so that when we start talking about hospital beds and how we're going to deal with crisis or people who might need an acute bed for a period of time, that we actually can have a conversation that's specific to the needs of that community. And that's I think that's why I want to be optimistic and encourage us to keep having this conversation, encourage all the players to come into this. Because I think one of the other dangers is we're simply going to relate to each other like we always have. There are going to be the old animosities and the old assumptions made about each other and how they can't do this or this is going to happen or, as opposed to saying, okay, the slate's clean right now. I mean, I know we've got bad things happening, but let's take the opportunity that this document presents and try and in good faith go forward with a new way of thinking, because the old way didn't work and it's not working. So what can we do to start that conversation going forward? What can we do to start planning, to start engaging folks in the conversation around this? We look forward to that. And one of the things, the other thing is, I think that to address this issue of how can we do this, practically speaking, what does it look like? Well, one of the things that we typically do with families, and we would be happy to do this with legislators and others, is to take folks around the state, because we can do it right, and we do it right sometimes in Georgia.
Well, I think you do it right, but there's a lot of questions about whether we have the infrastructure in place right now to do some of these things. Do you think we have the infrastructure in place?
No, ma'am. Okay. But that's the promise. The promise is that we are embarking on a grand journey to go and build that infrastructure.
Do we have the infrastructure in Milledgeville, in that area?
Not that I'm aware of, no.
All right, thank you.
Thank you.
Appreciate your comment. Oh, I forgot. I don't know what happened to my paper. Okay, come on. Go ahead.
Thank you, Madam Chair. My name is Greg Kirk. I have an advocacy organization in the state, and I advocate for people with disabilities. And I came today to speak, and I've got some good news, and I've got some questionable things that we need answers as well. In 1999, Dr. Sally Carter and I did the first training at Central State Hospital for the staff there to let them know what is in the community, what's available for these folks when they leave institutions. And I'm ashamed to say that was the first training that was done. But since then, a lot of work's been done, and I've learned a lot. Being involved with all the under 21 projects, moving a lot of people out of state institutions over the years, the closure of Bainbridge State Hospital many years ago as well. So I've learned a lot, and one of the key things I've learned about closing institutions is this: communication is key. You got to communicate, and communication with those families, and communication with the providers in the community, such as the Sheriff's Association and Hospital Association and so forth, as we move forward. So I got some good news today. The good news is that the division has a contract with one hospital in Gainesville, Laurelwood Hospital. They have contracted for some beds in that hospital to provide some services for mental health. I have some other good news. I've worked on 6 different work groups with the division this last year. And one of the work groups is a transportation work group Sheriff Massey and I both serve on, and Mr. Oliver in the back also with the Sheriff's Association. And we've come up with some solutions so that these crisis teams, these mobile crisis teams that the division is putting together, can do their own transportation when they go into a home or go out in the community. Someone's in a crisis situation, a 1013 has to be signed. You've already been educated about that. That these mobile crisis teams could transport those folks to the crisis stabilization unit. So that would take some of the pressure off. And there's some legislation that needs to change in order to bring that about. The division is also planning on contracting with 67 more beds in the community. River's Edge Community Service Board has put in place a person at Oconee Regional Hospital to help them with their crisis situations when people come in their ER. However, there's a lot of other issues that Oconee Regional is dealing with too that this doesn't address. So all of these matters have to be addressed. All of these things have to be talked about. And what I would say to the division, what I would say to the committee today is this. I stand here, having worked with them all this last year on these different work groups and having worked in moving people out of the institutions, cautiously optimistic. A lot of the right things are being put together, but I don't know that it's being communicated the way it should. I don't even know that anyone knew that this contract existed with Laurelwood Hospital in Gainesville, and that's information that needs to get out there. There's plenty more beds that are to be contracted with in the communities that would relieve some of the sheriffs having to transport so far.
So these beds take care of the people over in Milledgeville?
Yes.
Okay, in Gainesville, Georgia, the ones take care of the
No,
people?
not Milledgeville. Mark, the division would be better to answer that. Mark,
right.
where are these beds going to take care of?
Region 1, Rome.
Region 1, Rome.
Yeah, Gainesville.
Okay. And there's contracts for 67 more beds in that region, is that correct?
67 total.
Total beds in the state?
In the region.
In the region, thank you.
Okay, how many beds did you contract with in Gainesville?
There's 16.
16.
And there's 16 pending.
I'm sorry?
With 16 more pending, he said.
Okay, so 16 are available right now. Are they available now as we speak?
April 1.
April 1.
But the contract has been signed, is that correct?
No, it has not been signed. All right, thank you. And we're going to have to sort of limit our
Sure.
our conversation. Thank you so much and appreciate your comment.
Thank you.
Rita Young, if we could just sort of limit our comments, please. Tell us, what do you want us to change in the budget to
Right.
get this
Madam Chair, this is Linda Wilson, our board president. She's going to be making some very brief comments today.
And what you'd like for us to change in the budget to get this
I'll be glad to tell you that. Just as briefly, I live in Noonan. I am board chair for AADD, and I do have a daughter who is a young adult who has profound disabilities and seizure disorder. And I think what I want to say to you today is to support the current budget, because it is so important that people like Cheryl be able to continue to remain in the community. And as we talked about waivers, I think Pat talked about waivers. If we don't have that funding in place, then we are really going to be in a crisis situation. Then we get into where you're going to put them, how, whatever. So again, it is so important for us to have supports, the structure in place. Josh talked about it as well, so that people can stay with their families in the community. We have a good situation. Obviously, I'm with my daughter, but we are constantly looking for resources. We can't find them. There aren't providers out there to provide them for us when we need respite or that sort of thing. And furthermore, I look at the time when my husband and I are not able to do that. And when we are over the age of 60, as we've talked about, and so we're in that category too, that when we cannot do it, will there be personnel in place to support our daughter's needs? She relies on us for everything. So we have an opportunity right now with the Justice Settlement to look at how we place those tax dollars into the opportunity to allow people to remain in their homes on a regular basis. So that's sort of what I'm asking for. Whatever we do will not only help my daughter Cheryl, but will help the 19,000 individuals who live with parents who are over the age of 60. So I urge you to consider the opportunity through the Justice Settlement to let's place that money in the communities. Let's take advantage of the people who have worked in all these facilities and let them work in the community as well. I think we need to really be looking for those folks. So thank you.
Thank you, and thank you so much for coming. Any questions? Dawn Randolph.
Good afternoon, Madam Chairman, members of the committee. I'm actually going to read a statement from Ellen Yeager, who is the Director of Public Policy for Mental Health America of Georgia. Ellen is today transferring her mother from an independent living facility to an assisted living facility up here in Georgia, so she could not be with you today. And what she would like to share is, for a long time, Georgia has been a state which embraced hospitalization as a first step for seeking people with treatment for mental illness. This has resulted in Georgia having one of the highest admission rates in the United States. With the Department of Justice Settlement as a foundation, Georgia now has an opportunity to take the lead and transform the state's mental health system into a world-class system of care. Mental Health America of Georgia strongly supports the closure of the Northwest Georgia Regional Hospital in Rome as a first step in that transformation. People with mental illness need the opportunity to live, work, engage in religious and social activities, and be productive members in their communities. Mental Health America of Georgia also wants to thank Governor Deal, wrong year, and Commissioner Shelp in recognizing that the dates set for stopping admissions and closing the hospital are target dates and not dates set in stone. And that before people can successfully be moved into a community setting, there must be services in place. So the question now remains, what are those services and how will they be delivered? The closure of this or any of Georgia's regional mental health hospitals comes with challenges. Mental Health America certainly recognizes what is at stake. must ensure that the closing of Rome Hospital is done in a careful and considerate manner, taking into account that people will continue to need hospital supervision, but with supported housing, supported employment, assertive community treatment, case management, peer support, and crisis service centers, we believe that all people can live in the recovery given the right supports. Our high readmission rate demonstrates that we have used the hospitals as crisis stabilization, and we must ensure that these support services are up and functioning before admission is ceased. Thank you for this opportunity to speak. I'm sorry I couldn't be with you today. Your leadership can make great difference for thousands and thousands of Georgians.
You mentioned Rome Hospital. Has the admission ceased at Rome Hospital?
No, they have not. I think the target date was the end of April at this point. April 1? Okay, beginning of April.
April 1, okay. Thank you.
You're welcome. Thank you. And again, I'm sorry Ellen couldn't be here.
Okay. Neil.
I see her. Okay.
You see,
We're going by the list that was signed up.
Representative Manning, you're supposed to see recovery when you see me, not substance abuse. I'm working on that.
Okay.
We're working on it. Okay.
All right.
Good afternoon. Thanks for this opportunity. My name is Neil Kaltenecker. I'm the Executive Director of the Georgia Council on Substance Abuse. I'm also a person in long-term recovery, which for me means that it's been 20 years since I've last used alcohol or any illegal substance. I talk openly about my recovery every chance I get because I think everybody should have the opportunities that I do and I have had to get well. I'm here. I know we're moving really quickly, but I'm here in support of the current budget as it was proposed. And I know you're asking yourself, why are we here talking about substance abuse when we're talking about the closing of state psychiatric hospitals? I just want to give you a little bit of data. According to the Journal of the American Medical Association, roughly 50% of individuals with severe mental disorders are affected by substance abuse. 37% of alcohol abusers and 53% of drug abusers also have at least one serious mental illness. Of all of the people diagnosed as mentally ill, 29% abuse either alcohol or drugs. And specifically, 47%, almost half of individuals with schizophrenia also had a substance use disorder. That's more than 4 times as likely as the general population. And 61% of individuals with bipolar disorder also have a substance use disorder. And that's more than 5 times as likely as the general population. So we need to be talking about addiction and addiction recovery when we're talking about services in the community. These are from studies from all over, from the year 2000 to 2010. We get to the solutions real quickly. We should have a system of care in place that includes, first and foremost, taking into consideration that most of the folks coming out of state psychiatric hospitals also have a co-occurring disorder, and also that includes assertively mental health consumers, people in recovery from addiction, people in recovery, in dual recovery from addiction and mental illness, and their allies. So we're at the decision-making process at all levels. We're out here, and I know it was mentioned earlier that people with developmental disabilities have advocates and have a strong advocacy network without the state. Same thing with people in addiction recovery. You just don't hear about it as often, but there's a huge recovery movement. If you don't believe me, show up at the Capitol next week. Show up here. We're going to have our Recovery Awareness Day. There are strong networks and communities of recovery that are ready to help. Georgia is lucky. We're really fortunate with our work in peer support over the last years. We have a strong network of community treatment providers, including private providers, community service boards, the Georgia Association of Recovery Residences, which membership includes 55 current facilities and programs that serve approximately 1,500 people at any given time. So it's probably over 3,000, between 3,000 and 4,500 people a year. So we have a network of community providers that are out there. We also have a strong workforce coalition, and all of these entities are willing to help and partner with the Department of Behavioral Health to build a delivery system, and we should be at the table for all of these plannings. In conclusion, I just want to thank Governor Deal for the prominent coverage he gave addiction in both his inaugural and budget speeches this year, highlighting both the negative impact addiction has on Georgia's citizenry, as well as the financial burden it imposes on these tough economic times. And I'm quoting the governor, so don't interrupt me? No, you can't. I'm quoting the governor. He said, presently, 1 out of every 13 Georgia residents is under some form of correctional control. It costs about $3 million a day to operate our Department of Corrections. We know that about 75% of all inmates and people who are under correctional supervision have a substance use disorder. And he also said, for offenders who want to change their lives, we will provide the opportunity to do so with day reporting centers, drug, DUI, and mental health courts, and expanded probation and treatment options. As a state, we cannot afford to have so many of our citizens waste their lives because of addictions. So in the past, my agency, the Georgia Council on Substance Abuse, has been successfully involved in the development and sustainability of accountability courts such as these and working within the criminal justice system. We're uniquely poised to assist local areas in growing their communities of recovery and engaging other people in recovery to help with this process and people getting released from state psychiatric hospitals. We're ready to do more, but there has to be the appropriate funding in the appropriate places. Addiction prevention, treatment, and recovery services are out there, and we're ready, but we have to have those policies in place and make sure that we're all working together and not at cross purposes. We support DBHDD in its efforts to create a quality behavioral health delivery system, and we can create opportunities much like the ones I've had to get well and to stay well and develop safer communities. Thank you.
Thank you for coming to Shannon.
My pleasure.
Thank you. Todd, I'm not sure how you... Yes.
Well, good afternoon, members of the committee. I appreciate having the opportunity to present today. I am Todd Citron, the Executive Director of the Cobb and Douglas Community Service Boards. I have been the CEO for Cobb Douglas for 11 years. For the past year and a half, I've chaired the CSB Association, our State Trade Association's Executive Directors Group. So I'm representing our association, and I'm speaking, off the top of my head on a number of things that are, personal and professional. There are 25 community service boards in the state of Georgia that cover every county. They provide behavioral health and developmental disability services. First and foremost, what I ask of you is that you support Governor Deal's fiscal year 11 amended budget and the governor's fiscal year 2012 budget. We are supportive of the need to expand the number of assertive community treatment teams and other community support services, the creation of additional crisis stabilization units as alternatives to hospital stays, increased supportive housing, without which consumers cannot enjoy the benefits of independent living. I'll speak for my agency. We operate a 16-bed crisis stabilization unit. It averages 70 admissions per month. 850 folks who might otherwise go to the state institution.
And where are you located now?
Cobb County.
Cobb County. Could I ask you, since you're head of the association, are you familiar with Lookout Mountain Community Service Board?
Yeah.
And I understand that they're having to cut back their services. Are you familiar with that?
No, I'm not.
Is anybody here with that Community Service Board? I'd heard that somebody pointed out they were having to cut back their service. I wonder if it's something in the budget that we didn't put in.
That's true.
Yeah, Representative Neal.
I can't give you any details other than I did get a call today. That's in my district. I did get a call today from someone up there, and they are with their clinical and peer services going from 5 days to 3 days. And I'm looking into that to see if I can get some more information.
I didn't know
about
if it was
why that's
something in the
happening.
budget, if you were aware of something that we needed to do in the budget if they weren't being funded, or what the problem was. Because we're going to rely, I think, isn't that in Region 1?
Yes, Walker, Catoosa, Chattooga, and Dade County.
And so we're going to rely more and more on community service boards as this goes forward, I'm afraid. So I wanted to make sure.
There is the deliverables, the supports that are outlined in the FY11 amended budget. These are a new set of services. There's an existing array of services that have been underfunded for years. So, community service boards, other community providers have cut back to adjust throughout the years.
What I was concerned about was with the increased demands made on community service boards in this area with closing in Rome. Is it going to put more demands on Lookout Mountain community service boards? And if we need to look into that.
Yeah, there is, in regards to the closure of Rome, there are quite a few new deliverables, new services that are targeted for Region 1. There's ACT programs. There are 2 brand new crisis stabilization units. That'll be 32 new beds that'll be coming into the region. The contracting for the private beds, the 35 beds, will all be in the top region. So there are a lot of new services coming into that area. Some community service boards will be involved with providing, some other organizations. There's the department's in discussions with 4 private hospitals around the contracting for the private psychiatric beds. So there are an array of new services that are coming, in line with the closure of the state institution. Okay. I would like to mention in regards to supportive housing, my organization provides 108 units of supportive housing. Supportive housing is critical in this issue. We've got a couple supportive housing experts in the room, as a matter of fact. My supportive housing program, and we do some of the best stuff in the country with the supportive housing program, it is critical in regards to keeping people stable, independent, and moving forward and out of institutions.
Somebody, did you want? Rusty, did you have? Cost per bed. What's the cost per bed that you can?
For the private psychiatric beds? The 16 beds, the 16-bed unit, the budget is just under $2 million. For the majority of the time, the 16 beds are full. So 16 times 365 divided into $2 million, that gives you per bed day for a crisis stabilization unit. So,
it's how much?
About $340 a day. Okay, thank you. In regards to the existing array of services, we would like to echo the comments made last week at the Legislative Behavioral Health Caucus. The improvement requests are essential, but standing alone, they do not represent a complete picture of what is needed in a public behavioral health and developmental disabilities delivery system. Community service boards and other state-funded safety net organizations provide an extensive array of outpatient services, some community residential services, some supportive employment, and access to needed medications for tens of thousands of Georgians who, without access to these services and these medications, would be without. These essential services, so kind of an array of what's called core services, funding for these over the past couple of decades have eroded. And I think it's part of that that's put us in this position where there's an over-dependence on state hospitals. Without the existing services, even with the new added services, there could still be a reliance on a higher level of care like hospital level of care. So. But again, the expansion made possible by the settlement agreement really sets us on a very positive course in regards to moving into the future. So from where I sit, I think in my 11 years, we're at a better place than we've been in regards to moving the system forward. I am a proponent of closing institutions and shifting institutional money into community programming, and feel very strongly about that. Just in regards to Medicaid, Medicaid is a significant funding source for community services. Last year, Governor Perdue and the General Assembly exempted mental health providers from cuts in Medicaid reimbursements. However, the FY12 budget contains a 1% reduction in Medicaid rates for all providers except for hospitals and home and community-based waiver providers. Medicaid reimbursement rates are already well below any reasonable measure of the cost of providing the care. We asked the General Assembly to consider exempting community behavioral health providers and developmental disability providers from the proposed 2012 cuts in Medicaid reimbursement, just as you did in FY11, the FY11 Appropriations Act. So, thank you for allowing me to speak. Any other questions?
Thank you. Any questions? Thank you.
Thank you. Reminds me of the patient that tells the doctor, doctor, nobody understands me. And the doctor says, what do you mean by that? My name is Pierluigi Mancini. I'm the executive director of SETPA. I'm a nonprofit provider that receives state-funded services, funding and federal funding, and some private foundation funding. I'm also a person in long-term continuous recovery from addiction for 25 years. It's a pleasure to be here today, and thank you. I don't envy you. I really don't. I'm here to express my support as a provider for the current budget. I'm a true believer of community services. I'm a true believer that recovery happens in the community. I know that we have lots of challenges, but I also know that there's many solutions that can be available and that people have been working on for a long time. As a provider of prevention, intervention, and treatment services for addictive disease and mental illness, we support the transfer of services to community settings. We also concur with Commissioner Shelp about making these changes at the right pace to ensure that the services are in place before people are moved out. We also support the department in the creation of a new system, a transformation of our behavioral health system for all consumers in the state of Georgia. Thank you.
Charles Willis.
Good afternoon, and thank you for this opportunity to come before you and to express some interest. I'm a project director here in the state of Georgia. I'm a citizen of Clayton County, Georgia. And Sheriff Massey made a great example of the needs in the community when he said that he responded to over 200 1013s. I don't know if you guys know what a 1013 is, but it's a forced hospitalization. So if we didn't have to force people into hospitalization, then there may be an opportunity for him to alleviate some of the cost of transporting people, period. So I'm advocating that there be more community services in the community that supports the recovery and wellness of individuals living with a mental health diagnosis. National statistics say that there's 1 in 4 that are impacted by mental health. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. So you see there's a large population of persons who are impacted by mental illness. Now, some for the first time because of the downturn of the economy, others who have reoccurring conditions that because they don't get the services they need in the community, find a need to return to the hospital. There needs to be more community services in the hospital. Opportunities for independent living, peer support and wellness, these are new terms that are used by persons living with a mental health diagnosis to indicate their desire to self-direct their own recovery. And oddly enough, that's not a strange thing, because persons living with a mental health diagnosis are experts, and they're experts on themselves. They know what works and they know what don't work. They know what they need and they know what they don't need. So housing, supported employment, community services, and peer support are vital to the success of persons living in the community. There has been 2 new Freedom Commission reports, one while our own President Jimmy Carter was in office. At that time, back in the 70s, it indicated that some people could recover. George W. Bush in 2003 followed up with the new Freedom Commission report on mental illness. And it indicated that everyone has the capacity to recover. What is recovery? Recovery is a journey of healing that allows a person to live in the community of their choice. In the community, there should be an opportunity for housing, supported employment, services, and peer support. Oftentimes, decisions about what persons living with a mental health diagnosis receive are made by those people who don't know anything about it other than what they learned in the books. So we're happy to know that Dr. Shelp has invited consumers to sit at the table. I want to say in closing that February the 4th, which is Friday, I will celebrate 10 years in recovery. Prior to that, I was a homeless person here in the city of Atlanta, begging, borrowing, standing in soup lines. But something happened. I went to an AA meeting just for a cup of coffee, but in the process, I listened to a person tell their recovery story, which gave me hope. If this guy could recover, I could recover. Peer support is vital for people to recover. I'm a convicted felon. I've been in and out of institutions and hospitals for a very long time. I have a 7-page rap sheet. Listen, I started using drugs and alcohol at the age of 14. I didn't realize I had a mental health diagnosis until I was 47. I do know that when I was between the age of 6 and 7, I was sexually abused. I don't know which came first, the chicken or the egg, the mental illness that I self-medicated or the addiction, which brought on the psychosis. But I do know today I'm associated with the Georgia Mental Health Consumer Network, who's my employer. I'm a tax-paying citizen. I just recently bought a house in the community of Clayton County. And since my involvement with recovery, like most of us who are living with mental health diagnosis, we've experienced an opportunity to live and be respected. We ask that you consider us in terms of giving us an opportunity in the community to live a life of our choice, knowing that we are focused on living lives better and impacting the communities in which we live. The closing of the hospital in Rome, we applaud you for that, and we know that there can be community services that can provide for the consumers in that area in order to keep them well. So thank you again.
Thank you, and thank you so much for coming and telling us your story. Beth English.
Madam Chairman and members of the committee, my name is Beth English. I'm Executive Director of Easter Seals Southern Georgia. We're a 57-year-old private nonprofit organization that provided services in 2010 to 2,400 children and adults in 60 of Georgia's counties, most of them very rural. I wanted to let you know a couple of things. One, for capacity, our organization has been effective in using HUD Section 811 money, USDA community facilities money. We've worked with economic development authorities, both city and county, to transfer property to our name to develop community resources for housing, for program services, and just for a variety of needs in all those communities that we work in. We've also worked with families who have the means to make private donations of their residences or their family residence, and we have used those to create residential options for families in rural Georgia, which is where I'm from, as Madam Chairman knows. We have moved successfully people out of every state hospital in this state in the last 10 years, from babies that are 2 years old up to people who are in their 60s who spent the majority of their life living in state hospitals. They're successfully living in the community with the supports that they need to have meaningful, quality lives. And I truly, truly believe in this plan that the department has promulgated. I had 4 pages, but I'm down to 1 paragraph because everybody else has talked about what I want to talk about. The only other thing I want to add, Pat beautifully talked about families that are aging, that are caring for loved ones. The other group that are forgotten are the 800 plus special ed students that leave our public school systems every year, and so many of them go home to sit. And parents are forced to either give up their jobs and stay home with their child, or try to find someone who can. So as you're looking at this budget and you're adding funds to do the services, please consider those young folks who have so much potential. We don't need to lose that human capital. We don't need to make families make those difficult choices. Young adults with disabilities need the opportunities to work, to grow, to learn, and to continue to be contributing members of their communities. So Easter Seals stands on record as being in support of this plan. We are active players in this process. We work with all of the agencies in our community. When you live in South Georgia, you can learn how to hold hands and play good in the sandbox together. So with that, thank you so much for the opportunity to come and say my piece, and I thank y'all for the support y'all have given us over all these many years, and I've enjoyed working with so many of you all for the last, I'm not going to say how many years.
Thank you, and thank you for the job you do and what you do for children in this state. We appreciate it. Frank Berry.
Hello, and thank you for the opportunity to speak to you all today. Madam Chair, it's great to see you, and distinguished members of the committee, thank you for the opportunity. My name is Frank Berry. I'm the Executive Director of the GRN Community Service Board, which is Gwinnett, Rockdale, and Newton Community Service Board. We serve approximately 10,000 people a year in our community in a variety of different settings, from outpatient services, which individual counseling, psychiatric appointments, nursing assessments, to day programs, and residential and crisis programs. The GRN Community Service Board supports the Department of Behavioral Health and Developmental Disabilities budget request. We feel that this budget is the best avenue to date to begin to serve people in the most appropriate environment that is conducive to recovery, and that is closer to home. Community partners that include consumers have been developing locally owned models that would keep people closer to home for their care and provide better outcomes for those consumers. By keeping them more closely in their homes, they're closer to their families. I have a 10-year-old and a 7-year-old. I can only imagine what it would be like to have to send one of my children away to a hospital that was several hours away. That would be unacceptable to me, and I would do everything possible to have that not occur. We as a community feel that we can provide better outcomes and hold community providers more accountable at the local level. This budget allows for local ownership by having the dollars come to the communities to develop those local services and find high-quality providers to provide that level of care. As many of you know, the facilities in Georgia are very old. We will never be in a financial position to renovate all of that needs to be renovated. It is time to invest in our future and invest in our communities. The laundry room in Central State Hospital requires millions of dollars to renovate. I wish that those millions of dollars could be turned into community services. I met a family earlier today from the Northwest, and I want to applaud them for being here. They talked about their daughter, and they talked about the mall up in the Northwest. When the question was asked earlier today, what can be done with those facilities? I see no reason why some of those hospital grounds could not be used for community-based services. There are creative ideas, and I think that I hope to hear more about this mall concept where services are provided out there. There are opportunities for staff in the hospital settings. We cannot look at this as a way to save state jobs or save people's jobs. We have to look at the consumers that we're serving. There are opportunities in the community for hospital staff to come and work in the community. We, in the last 2 years, opened a crisis stabilization program for children. 95% of our staff came from the state hospital. 95% of those 70 staff came from the state hospital and now are working in a community-based crisis stabilization program. So those opportunities do exist. Again, I want to thank you for the opportunity. I do envy your position because I think that you're in a leadership position, and any time you have the opportunity to make difficult decisions that are in the best interest of our citizens, we appreciate what you do. So thank you.
Thank you, and thank you so much for coming, and thank you for what you do.
Thank you.
Pam Bolster. No? Oh, it looks like Pam. Excuse me, Paul, you write like Pam. I'm sorry. Look, tell me, does that look like Pam to you? I'm so sorry.
That's all right. I respond to just about anything.
I'm sorry.
I'm Paul Bolster, and I'm the...
I'm embarrassed as many times I've heard you talk.
I'm the director of the Georgia Supportive Housing Association. We're a small association of about 38 different organizations that want to expand the number of supportive housing units in the state, mainly because we think it works for people that want to live independently, and it's more effective than an institutional approach that the state has dominated the state policies in the past. Just to let you know a fairly simple definition of supportive housing, it's housing that is affordable. In other words, people have got to be able to afford the rent, or the rent has got to be at the level where they can afford to pay it, and it's connected to quality support services. That alone combines a lot of different programs and policies of the state, because the supports come from one department, the housing comes from another department, and in many cases the local jurisdiction is responsible for developing the housing and using its housing resources. We're very supportive of the settlement that happened with US v. Georgia. It is a wonderful framework to begin thinking about developing a broad-based community mental health system, of which we hope that housing is a part of that. We're very supportive of the fact that Governor Deal has committed to fully implementing the settlement. Now, the settlement in terms of housing, you hear a lot about the services that are in the housing in the settlement. There's two kind of goals. It says in one place that the state should have the capacity to provide supported housing to 9,000 individuals. In another place it says the state should have 2,000 supported housing units. The best I can understand, the difference between those is the 9,000 goal means that you're going to use other housing resources that are at the availability to the state. The 2,000 goal is more or less a commitment to make sure that there's a floor where people don't qualify for these other housing programs. A lot of other HUD federal housing programs had very specific kind of requirements. And in many cases, some of the clients that you're trying to house will not fit into those. So this is a floor. And what you have in the budget is the minimum under the settlement. I remind you that the department asked for some more. They asked for about 1,000 units, or a capacity to put 1,000 people into supported housing. And what you have is 100 in the supplemental, and you have 500 in the 2012 budget. The way it phases in over the course of the year, that's probably enough money. Realize that this is a 5-year plan, so it's going to ratchet up each year for the next 5 years so that you can support the 2,000 units. But the big question is, what about the 9,000 goal? And I'll talk about in a minute that I think that's a little small, but the 9,000 goal needs to commit a lot of federal dollars. And I have put in my writing there all the different types of federal dollars that there are out there. You know, Section 8, Shelter Plus Care, HOPWA, there's a VASH program, there are low-income housing tax credits, there are home funds. All of those funds have been available to the state for many, many years. The problem has been that the state has not allocated or targeted those dollars for supported housing. The state needs to transform those programs so that you're producing more supportive housing. The tax credit program in North Carolina developed a 10% goal back in 2004, and from that they've created 1,600 units of supported housing in the state by funding it through the tax credit program. So there are lots of different ways in which these federal dollars need to be reprogrammed. Now, the other important next step, I believe, is to have a supported housing plan. You heard the sheriff talk about the needs in the local jails for people there. We need to find out what the number is of people that have mental illness that are in the jails who have unstable housing. That can become part of our housing goal. We need to find out the number of people that are repeatedly using emergency rooms at the hospital, and it's because of their unstable housing situation. Or the number of people in nursing homes that could easily be living in our community, and the number of people in homeless shelters. You can see this is a fairly large group of people that really is the target of the settlement, even though the language and the number goals aren't as specific as maybe as large as they're going to need to be. My hope is that this goal and this settlement gets us thinking more broadly about the issue of what people need in terms of community services. And I think when we start thinking, it opens up a door of wonderful discussions both in the local community and here at the state level, so that we can begin to think about how the state efficiently and effectively meets these needs. We haven't talked much about this yet today, but I believe supportive housing is less expensive than the emergency institutional system that we use today. We need to, one of the last kind of warnings here is the housing agenda is very vague, and in this group there are a few people here that work on housing issues, but tends to get it'd be an unusual thing for the state government to work on housing issues. I believe that the housing is the most critical part of success for the settlement and for this population. If you think about it, you're really closing the door of a hospital in Rome, and if you don't open up a door in a home in the community, then there's no place for that person to get their treatment. The treatment is going to be more effective if they're in a home. Just a final little kind of catchword, please think about housing as health care, not as just housing. Thank you.
Thank you so much. We're going to have to deviate a little bit from our plan. And Jean Acock, which has a meeting after this, do you mind if she goes on? She's got a family. Oh, thank you. Thank you.
Thank you, Madam
so
Chair.
Much, and thank you for being so kind.
I appreciate the accommodation very much. I am Jean Acock. I am the CEO of Oconee Regional Medical Center in Milledgeville, Georgia. And I was asked just to share a little bit of the experience that we've had since the closure of Central State Hospital, because I believe it's incumbent on the committee and the department and everyone as further plans are made to... Wasn't me.
Okay,
to implement the settlement, that perhaps some of the lessons that we have experienced maybe need to be learned. I've heard a lot of great things today about what's coming and what needs to happen for the patients, and I want to be clear that the patients are my number one priority as well. Unfortunately, we are seeing far too many of them in our emergency department because we no longer have the resources of Central State Hospital, and we did not have preparation in our community for these resources that these mentally ill patients were going to need. During the last 6 or 7 months, we have had 345 behavioral health patients in our emergency department. 78% of those have come from home. So there are lots of needs there and lots of people who are living at home but that are still responding by coming to the emergency department for help. Preparation and training need to be done in all of these communities. So as you're looking at this budget, and I must say that I'm not familiar with all of the different budget requests for 11 and 12, but I hope that they will contain quite a bit of community preparation and training, funding for the alternatives. The Sheriff Mashlee mentioned what he has done on his side. I can tell you that the hospital has funded itself $104,000 of just sitters and security personnel in our emergency department to keep the behavioral health patients, the community patients, and our staff as safe as we possibly can. This is not our area of expertise. We do medical care, but behavioral health has been a challenge for us. So we have had to fund this transition ourselves. The needs that are also there for managing the medication of patients that need to be out in the community on their own and living needs to be addressed by the state by hiring physicians to work in the state hospitals to do medical management of these patients. We have admitted 21% of that 345 patients have been admitted for a medical issue, and that's obviously something we want to help them with. But the physicians that we work with at our hospital are not experts in psychiatric medications. So they often remove these patients from their medications, treat them for their medical issue, and then once the patient is discharged, that challenge of bringing them up to whatever therapeutic level or rebalancing of medication is necessary. The state needs to take a look at that and address that. So perhaps they aren't in a community hospital. They might be in a setting where that both issues could be addressed at the same time. And I'm not sure if that's been looked at or discussed in any way in the budget. We are very thankful that the department did provide us with a contract provider in River Edge. We do now have someone in our emergency department that responds and helps us with the immediate crisis of someone showing up or a 1013 that needs to find placement in a state hospital bed. And they've been a godsend to us, but that's only the tip of the iceberg. And just understand that I think all of these plans are great. I understand what we've got to do with the DOJ settlement and that there are a lot of things to be worked out because because of budget constraints. However, careful preparation needs to happen because you're laying the costs, you're laying the challenges at the doorstep of the community. We don't receive funding from our county in any way, and 34% of these folks have no insurance whatsoever. Another 26% of them are Medicaid. So about 60% of these are very much challenging for us. So about half of the cost of the care of these 345 patients has been borne by our hospital. And so we can't take a whole lot more of that without some kind of recognition. So just want to be able to share some of these experiences as the committee oversees these important tax dollars and this settlement on the other side of what can happen. I think the plans are wonderful, but I'm with Sheriff Massey. We've got to worry about today as well and what's happening.
I've got a couple of questions. How long, you said you saw, I forgot, how many people in the emergency room on mental health issues?
We started tracking this in July of 2010, so over the last 6 to 7 months, we've had 345 patients.
340. What is the average stay in the emergency room for?
The average stay, and
Did they stay in the emergency room overnight?
Well, 72 of those patients were admitted up onto the floor. Sometimes we have to put them in ICU because as we're waiting for a bed at the state hospital, they need one-on-one care and observation. Perhaps they've tried to commit suicide or something where our staff feels like it's important that they have a lot of personalized attention until they are admitted to the state facility.
How long does the average person have to stay there before you can find a bed to put them in?
Well, the average time during this period has been about 10.4 hours. I've seen it range from, I reviewed it last night, one patient was lucky. We had them with us for an hour and a half, and I don't know, they may not have needed anything other than stabilization and to be sent back to their community provider. But we have also had a gentleman with us recently as this week for 48 hours in our emergency department. And that's a real struggle to keep them there while we are waiting on being able to call Sheriff Massey to come help us transport them for wherever there's a bed available. So more beds are desperately needed for those in crisis. Perhaps not in long-term institutional care, but these crises are still going on. We have a high per capita instance.
Suicides and that kind of stuff. Are we talking about mental health patients that just fail on their medication? Or are we talking about, I mean, you know, if you don't admit them, what do they show when they come through the door?
Well, the majority of these probably are those that have had some 1013 involuntary, temporary stay at a state facility, addressed, or that they have some kind of need for that. But there are many who do not have medications, or they get off their medications and are having various issues that might present as medical. Could they be having a stroke? Could there be some other medical issue that's happening because of their behavior or other things like that would cause someone to bring them to the emergency department?
So what's going to happen when we don't have these services available at your hospital? What's going to happen to these 273 people?
Well, I guess we'll keep coming to our hospital. I'm not certain what's going to be the answer, but there are still very many crises going on because we don't have the community programs and services that were in place prior to the closure of Central State. We didn't realize how valuable Central State was to many of the patients in our area until we no longer had them. I think they were underappreciated in many ways. They were the source of first and last resort for many people in crisis. Now they don't have that resource, and so the community hospital has become that resource.
Where do they transfer to in crisis? Is this team?
Well, the folks from River Edge help us just maneuver wherever in the state hospital program that there might be beds available.
The River's Edge, is that located in Macon?
They are based in Macon, but they have an outpatient facility in Milledgeville, and so they have contracted to have people either in our emergency department or responding to our emergency department to help address this when we have patients that arrive.
Has the state contracted with you to have any psychiatric people in your hospital?
No. This contract did come about. I understand that there's also been an ACT team that has been funded for the Bibb and Baldwin region. I believe that the hiring has begun and that team is going to begin enrolling, but that's a long process, I think, that will take many months.
So there's
for
no
us to see.
ACT team in place in your area?
There is, yes.
Where is it?
Bibb and Baldwin, serving Bibb and Baldwin residents based out of Baldwin County. Model fidelity requires that you can only admit 4 to 6 clients a month. We're funded for
What? I can't wait. Would you stand up?
The mic.
The mic.
Press the button, please.
So you do have an ACT team there. I'm surprised that your hospital doesn't know about it.
It's just begun.
I mean, you had
I'm Shannon Harvey with River Edge, and Gene and I have had many conversations. We were funded this year for an ACT team. We went through the process of hiring and training, began serving in October. Model fidelity requires no more than 4 to 6 patients per month can be admitted. Currently, therefore, we have 15 patients enrolled, 15 clients enrolled with 2 pending admission into the ACT team. So in a little over a year, we'll be fully serving per model fidelity.
Which is 100, correct.
Well, what do these people do that you're not funded? You can only take 4?
We're allowed to take 4 to 6 per month.
Well, what about the overflow? What do you send them to the hospital?
No, ma'am. River Edge Behavioral Health Center is a community service board that serves 7 central Georgia counties. We are the partner of the Sheriff's Department and Oconee Regional Medical Center. As Gene can attest, we do virtually everything we can do to keep people out of the emergency department, including a partnership where we draw the labs. She comes and gets them and runs the labs so they don't ever hit the emergency department. So we run a full complement of outpatient services in Baldwin County.
Representative Tesla.
Thank you. Question from the director of River Edge. If you're full and you can't take more people, if there's no room at the inn, as it were, what do you do if you've got people that show up that need service? What happens to them specifically?
We first look at what is their clinical need, then we look at what is their payer source. If they have a payer source, we seek to facilitate their admission to any hospital in Georgia that accepts that payer source. We also look to other crisis stabilization units in our region, and as a very last resort, we look to the state hospital.
So in essence, you look at neighboring crisis stabilization units that have space, and you sort of serve as a broker to help facilitate them getting there. Is that basically what happens?
Crisis stabilization units or any other psychiatric hospital, not just state hospital.
Okay, thank you.
Thank you. Yeah, we're through. And everybody wants to speak, so we're really going to have to limit it. There's a meeting coming in here at 4, and we're going to have to really limit our things to about 3 minutes, if you could, so everybody could get in.
Okay. My name's Eric Spencer. I'm with NAMI, Georgia. I thank you, Madam Chairman, and the committee for giving me some time to speak. NAMI, Georgia supports the settlement and the governor's proposed budget to implement this settlement while continuing to fund existing services. We also agree with Commissioner Schultz's statement at the Georgia Behavioral Health Caucus last week that the proposed budget represents a minimum floor, that there always could be more. NAMI, Georgia does not support the closure until the appropriate community services are in place and can be proven effective. You've asked the question, Madam Chair, what do we recommend to the budget? What I would recommend you do for the budget is to make sure that the department has the funds to invest in community care prior to the closure of the hospital. It's not like cable service where you can stop paying one provider and pay another. It's like building a house. You have to live somewhere until your house is built. So please provide them with the funds to build the community services up first, then close. And that's that next statement. Closure of the hospital should be driven by an achieved reduction in demand by effective community-based services, not by a planned target date and hoping that the community services will be up to the challenge when the doors close. But that's about the hospital closure. What we recommend is the focus shift from the hospital closure to the provisions of community services. Information on the community services has not had the level of detail yet that would assure nervous and apprehensive communities about this closure, that this won't be any different than last time. We're sure that there's a detailed plan somewhere, and that we really hope and share Josh Norris's optimism that this plan will work. But it needs to be brought out so that we can know about it and be assured by it. We also appreciate being informed about the closure, but we believe that engagement with community stakeholders will be a better way to do it. Community stakeholders have a knowledge on the ground that the department folks might not know about. For instance, the information about Lookout Mountain going from 5 days a week to 3 days a week. Something like that might need to be factored into the plans. What Terry Norris brought up about the beds needing to be secured. The local community stakeholders know these things, and that kind of information can be invaluable to the process. So we suggest that a community stakeholder involvement be done. Back in 2009, when the DHR announced the closure of the Savannah Hospital, NAMI Georgia, along with our local chapter and the DHR, convened what became known as the Region 5 Summit. Governor's Perdue office, the DHR, law enforcement, mental health courts, local providers, and stakeholders from the entire region came together and developed a plan for community services. The report that they developed led to NAMI Georgia receiving funds that led to $2 million of private money being put into the region to implement and improve behavioral health care in Region 5. Now, in this instance, NAMI Georgia and our local chapter, NAMI Rome, are planning to immediately host and facilitate a Region 1 summit. We're inviting everyone to come to that and be a part of an effective community stakeholder collaboration to develop the delivery of mental health care delivery system in Region 1 to meet the challenges of the settlement and our citizens' needs. The first meeting is going to be February 15th. You all have an invitation, and if anybody else wants an invitation, we have plenty here. We hope that Governor Neal's office, the department, and the Region 1 legislators and this committee will work with us in reaching this goal. And hopefully we will have a very similar outcome of bringing in additional and very much needed funds into Region 1. Thank you.
Thank you so much, and thank you for what you do to help make this transition easier. Let's see. Did you have something else you wanted to say? Okay. Okay. All right. All right. All right. If we could sort of limit our speeches.
Okay. Hello, my name is Jean Boone, and I am the director of the Baldwin County Milledgeville Outpatient Site for River Ridge Behavioral Health Center. I speak to you today feeling like I have survived being at ground zero with the sudden and shocking closure of Central State Hospital Adult Mental Health Services in November of 2009. As has already been spoken by Ms. Aycock and Sheriff Massey, our community was shocked. We were not prepared for the closing, and we have been reeling for months since, and almost a year or longer than a year in trying to stabilize our community and in trying to develop a new normal for our Baldwin County area. We have recently talked with Commissioner Shep, and he has explained that he felt forced to do this due to the serious and repetitive negative patient events that were happening at Central State, the fact that the old facilities could not be modernized and the cost was prohibitive, and the real and imminent threat of the Department of Justice takeover, and the fact that he could not discuss that due to pending lawsuits. Still, our community has scrambled, and I want to stress that out of the crisis, we have developed community partnerships that have begun to develop a new way of working and to try to assist our citizens. The department has invested in helping Baldwin to stabilize to some extent. However, additional investments are certainly needed in the Baldwin area. Some of the partnerships have already been referred to with Oconee Regional Hospital. We are doing the lab partnership so that individuals don't have to go to the emergency department. Sheriff Massey already mentioned that the department has provided a psychiatrist to help at the Baldwin County Jail. However, there were 291 inmates that were treated there, which certainly shows a high rate. The department has contracted with the River Edge, my site, to do the mental health assessments, facilitate dispositions and procurement of crisis beds and hospital beds for individuals. That has helped reduce the emergency room burden. It has also reduced the wait time on an average of 1.5 hours prior to our involvement. There was 12 additional crisis stabilization beds that were developed with new department money that has reduced the state hospital load. It has also reduced the ability to provide services to our residents in Macon, which is only 45 miles away, versus the 2.5 hours that was going to East Central. We have funding for the Assertive Community Treatment Team, or ACT, which is serving individuals. And even though it's 15 individuals at the moment, we started in October. We're providing, we're admitting new individuals every day, up to 6 to 7 a month. And these are individuals who historically were hospitalized many times at Central State. They have history of multiple arrest records, incarcerations in the county jails, being in the emergency departments. Many were homeless, and at this time, all 15 have homes. None have been rearrested, and their lives are better. So I ask you to support the budget requests that will allow additional community resources, such as the crisis stabilization programs and the ACT teams, because they do work. And especially, I haven't been privy to the information regarding the closure of the Rome Hospital, but I am clear about this. If it is to happen, these community resources need to be in place before the closure so that communities can be prepared. We were not allowed to, we did not have that luxury, so we have scrambled. We have come together as a community. The department has helped. We're asking for additional assistance, and we support this budget.
Thank you.
Okay.
I also want to come to you and speak my name is Shannon Harvey, and I'm the Chief Executive Officer of River Edge Behavioral Health Center. Though we serve predominantly central Georgia, 44 residents of 44 counties surrounding Macon look to us for outpatient care, and we serve in our residential services all but 10 counties of Georgia. So we're honored to speak to you today. If there's ever anything that we can do to be of service to you, it would be our honor. I speak to you in support of the budget that's been put forth by the department. Why is that? We know that treatment and appropriate supports are effective, and recovery is to be expected for persons with mental illness and addiction. Though we absolutely believe that hospital beds are needed and have their place for stabilization of individuals with the most serious illnesses in the most acute phases of their illness, crisis stabilization units are a viable option for most. Also, except for the smallest number of forensic clients, custodial care is not an appropriate option. Research proves that with appropriate active treatment and access to supports like housing, case management, training, jobs, etc., people can have meaningful life in the community. Research across multiple states also proves that persons with developmental disabilities previously served in institutions have better lives in the community, more social contact, and better functioning. This DBHDD budget request comes closer to requesting funding for appropriate treatment and supports to foster meaningful lives in the community than any in recent memory. You've heard about some of the things that River Edge can speak about with the greatest personal knowledge and those positive outcomes. Mental health assessment and disposition facilitation at Oconee Regional, the ED load is reduced. The time in the ED is reduced by 1.5 hours per patient. The 12 new CSU beds, more persons have been served. The time to admission disposition is shorter by 8 hours. The shorter travel distance for Baldwin Sheriff as compared to East Central is 45 minutes versus 2.5 hours away. Assertive community treatments teams, though it takes a while to serve the entire 100, the people currently served experience better lives. Please support the DBHDD budget request. I welcome your questions. Thank you.
We're almost through. We've got three other people, and we've got somebody else coming in, and I don't want anybody to sit here this long and not get to say their speech. So, thank you.
Well, thank you very much, Madam Chairman, members. My name is Paul Newell, and I probably need to qualify my presence to some degree. I am a retired district health director for the public health system in Georgia. Proud to say that. Worked for the state and was there to help. But I'm here today representing Bartow Health Access and its Behavioral Health System Improvement Work Group. Bartow County, as you probably know, is located in Region 1, next to Floyd County, the home of the hospital that is being closed. Bartow Health Access is a non-profit entity that was established to provide free and low-cost care for indigent and uninsured patients in Bartow County. And in the course of its work, the Bartow Health Access encountered people regularly who were in pain and suffering as a result of unmet needs for behavioral health services, serious unmet needs. To begin to address this problem, and I'm speaking to you now as a person who is invested in the community health planning process, we started with a community-wide survey followed up by a series of focus groups to identify the kind of issues the sheriff, the hospital CEO were speaking about, and to establish some priorities. The work group was formed in 2010 and has been working on those priorities since then. We have a community stakeholder group which consists of leaders from all of the groups that we have identified as stakeholders, and believe me, that's a broad range. We now have them meeting quarterly to hear reports, support the work, and recommend action steps. What we're working toward is a community-based, community-defined behavioral health system of care, which has a number of essential elements. We want to be sure to state that we are in support of the closure of the hospital, but like most of the other speakers, we have deep concerns about closing admissions before the services are properly in place in the community. So we see this as an opportunity, not only for this county, but for the state to really work toward a behavioral health system modernization. We have included in the documentation that I've provided an outline of what we think would be required for our county to fill the gaps that currently exist and to supplement services that are being provided by our local community hospital and our community service board, as well as others. We know that some of those services cannot be made available within the confines of the county. An ACT team may be an example of that. We know that some of the services will be critical to be available within the county, things like a mobile crisis team, peer support program expansion, some kind of peer support and wellness center. These kinds of things we believe are critical to the development of an effective behavioral health system within the county, within Bartow County. Our intent, we've shared our thinking with the department, and our intent is to pursue funding and support to make this happen. So what's going on now? We're strongly in support of it, and thank you for the opportunity for bringing this to your attention.
Thank you so much.
Mm-hmm.
Let's see. Eric Spencer. Oh, you've already tried? Bonnie Moore.
Thank you for the opportunity to speak. I come from a different point of view. I come as a mother of a child with mental illness, a severe mental illness. And I come as an advocate for the phone calls that we get daily, sometimes 3 and 4, from parents saying, where do I go? What do I do? Where do I turn? And in this day and time, right now, they're not the services that we need for our mental illness, for our people with mental illness. I applaud what the DOJ and the state of Georgia has come up with. But my concern from hearing today, it might take a year to get an ACT team started. What about the other services? The people at North, and I'm also representing the staff at Northwest Regional Hospital. We're getting phone calls daily from staff saying, we have a piece of paper that says we are terminated June the 30th. I know yesterday someone called and said 8 nurses have left Northwest Regional Hospital. To me, that leaves a gap in services. My concern, and should be the concern of the other people in this room, that if people are leaving because they think they are without jobs June the 30th, what happens to our system of care for those in the hospital? Those at Northwest are still under the assumption the hospital is closing June the 30th. We've heard that that's a target date, but employees don't know that. And it concerns me when we have people that are chronically mentally ill that have been in services and the only place they can go is in the hospital. We get those daily. Now, we talk about we have to have family components wrapped around it and community services. What happens to that mentally ill lady that I have dealt with that has been put into community services, that has been in private hospitals, that they finally had to, she's been in group homes, they couldn't contain her anywhere. She is now at Northwest permanently. What happens when they move her to Georgia Regional, Savannah, or wherever? Family services will not be wrapped around her, nor her community will no longer be wrapped around her. I think what we've got here is a plan that's going to work. We need to think through it, and as I've heard today, we need to make sure these services are in place before we take away our safety net. And to look at, in 2006, we had 300 beds at Northwest Regional Hospital, of which there were 130 adult mental health, there were only 40 forensic, and the rest were DD. We have 65 beds at Northwest Regional Hospital today for adult mental health. And it looks like we've done a great job, but the funding has been taken away, so they had to take the beds away. And we have not kept a good record of how many have gone to our jails and into our prisons and are homeless. I want to work as an advocate with the department and with the DOJ to ensure that my child or whoever else's child receives the services that they should receive.
Do I have any questions? Thank you. I want to. Now, let me see. You said that the beds were down to how many in North?
65 adult mental health for 31 region. Acute mental health beds in Northwest Regional Hospital. I believe that's the right figure. 65 adult. And in 2006, there were 130.
Does somebody track these patients once they leave as to where they go or what happens to them? Or?
I don't know.
But is there? I know when you have people in nursing homes, you have an ombudsman.
Well, and that's the other problem. We've had an ombudsman that was funded for a long period of time, and we had Jewel Norman, who was in that position, and had to leave the position because of health reasons. We do not have that ombudsman, and the ombudsman, that's one of their things, is they are supposed to be tracking a lot of this critical information. And right now, I'm not sure we have all that critical information. If Joel, I can't answer those. I'm an advocate and I'm a mother, so I can't.
Representative Oliver.
In addition to the 65 beds, how many other patients in any other capacity are being served?
Right. Well, we're up to 70 forensic patients right now, whereas in 2006 we had only 40 forensic patients. And I think someone alluded to the fact that there were 200 people awaiting in our jails for mental health that had been court ordered to hospitals.
So the total number of patients on the Rome facility is about
180.
180. So that's 70 forensic and 65 mental health adults. And then
and I want to clarify, that's beds. So we need to be also looking at, those are just the number of beds, how many people are transitioning in and out of those beds. So, we're talking about beds. We're talking about more people coming in and out of the hospital than just 65.
And there are 700 and something employees that are serving those 100 to 50 to 200 people coming, or maybe more.
But also you have to remember, a lot of the DD patients have a lot more one-on-one than you would if you had adult mental health and or forensic. And forensic doesn't have nearly the amount of people.
How many acres are on the campus?
I think roughly 120, somewhere around there, I believe. Somewhere like that. 140? I was a little bit off. Close.
Go ahead. Representative Kessler.
Madam Chair, thank you. Thank you for coming today and sharing with us. You've raised a question that, if it pleases the Chair, I'd like to ask perhaps the Department. The issue of the hospital as it gets closer to a date of potential closing, the attrition of employees looking for jobs they can, frankly, proactively go find. Is there anything in place? Are there any protections in place, whether it's employee contracts, whether it's sort of a backup contractor providers to make sure there's...
Can I say something kind of to that? I had, on the way down here, I got a phone call that on the, I believe, 19th, when they were given their slips of termination, they were told that, and this is hearsay from people coming to me, so I want you to understand that they would be able to transition to other hospitals. I got a kind of a frantic phone call today saying there are people that are licensed that have gone to other hospitals within the state system, and they have been told their licensure will not transfer from that hospital. People have been there anywhere from 5 to 20 years.
And again, Madam Chair, my concern is there may be some specialties that would have to be present to make the hospital functional. Again, I'm not a medical professional practitioner. I don't know the details, but I'm just concerned that there might need to be some provision in place to ensure that a certain level of care is maintained. I just get a head nod from folks that that's been taken care of. Can anyone in the audience speak to that? Okay. Thank you, Madam Chair.
You want me to hold mine too? Go ahead. I just wondered why the hospital is closing with all of this need, and these people have nowhere to go. I mean, what's the reason for the closure?
From what I've been told, it has to do with monies.
Money.
That was, I mean, I don't know, but that's what has been told to me, that it has to do with monies, and that Region 1 already has some good services in place, and so it would be easy for them. We are looking at, I believe, a 2.1 million population, this hospital services.
Okay.
I'm concerned about, I know, what happens to some, these people when they leave the hospital, when they've left the hospital, what happened to these and who keeps up with them? Does this, and I hate to even say this, did we cut out an ombudsman for your area? Or?
No, the state of Georgia, Joel Norman, who was our ombudsman, was a wonderful lady. Due to health, had to resign her position. And I believe that was done several months ago. I'm not sure exactly when, August. And no one has been hired at present to fill that position. I don't know if no one has applied. I don't know why, but I just do know that that position has not been filled. I didn't know if we didn't fund that position or what, but we'll find out. Thank you, and thank you so much for coming down and sharing with us. Rusty Kidd, he's going to be very brief. He's going to speak from the floor. He's up to speak.
I'm talking to y'all, not these folks out here anyway, so I'll look to whom I'm talking to. I could go on for an hour if but I'm obviously not going to. Sheriff Massey and myself grew up around mental health. And unfortunately, I'm not going back upstairs to go through the archives and get another broken neck like I did a couple of weeks ago. Going back to where my father tracked mental health when the state was only paying 18 cents a day per patient, then 25 cents and so forth. So we've been around mental health our entire lives. I can tell you that, and I will respond to the committee in writing if you'll let me about a lot of things that took place here today, that some accurate, some people talked with some misinformation and so forth, and the best ability I can will respond to you that way if you'll let me, Madam Chairman. But I can say that, in answer to the last lady's question, that treatment modalities have changed a lot in the last 100 years. They've changed a lot in the last 10 years. And I think that's one of the main reasons that some of the facilities are being closed and so forth, because of the different treatment modalities. And some of the buildings aren't equipped today to treat people with these new treatment modalities. I say that at the same time that I wish some of the facilities had not been closed in Baldwin County, just strictly from an employment aspect and jobs in Baldwin County. But to be honest about it, that's a lot of what's taking place. But I think you do need to learn all the facts about what's taking place. The $17 million cost of a contract that the state entered into last year that none of y'all really knew about until after the fact. The fact that each of the 6 hospitals were asked to pony up $500,000 out of their existing budgets to begin paying for this contract and stuff like that. And the fact that individuals said that communication is great, to go down to the hospital and communicate with people, and it is. It's a very important thing. The first meeting that the department had in Milledgeville, and I'll quote the beginning statement of the individual who said this, and I even called him one time and said, I want to talk to the person who understands the meanest SOB in Baldwin County right now. And I said that in jest just because I wanted to talk to him. But the way they opened the meeting was, it's been said in Baldwin County, hell would have to freeze over before they closed Central State Hospital. Well, won't you know, hell just froze over. That was the first way they started addressing the meeting. And that's not the way to communicate to employees who dedicated 20 or 30 years of their life treating patients and so forth that you and I would never go treat. That's not the way to do that. I think the department has learned a lot because that's the way they handle folks in Baldwin County. And I don't think they're treating employees quite as bad as they did in the past. And I think the department does want to try to place everybody in other situations, be it 30, 45, 55 miles away. But that does disrupt the family who, here again, who's been treating patients in these hospitals and in these facilities for years, and are very dedicated people treating these patients. But I'll close with that, Madam Chairman, and welcome the opportunity, and I will in the next few days put all this in writing and give it to you and anybody else who might want it.
Thank you. I think everybody's had a chance, and we were going to hear from Dr. Shepard. If you'd like to say something, time's sort of running out, and I don't want to end it like this. If you'd like to say something, we'll just...
I think the only thing I can say in the amount of time left here is that we've appreciated all the comments that have been made. There's a great deal I'd like to be able to say if there was another opportunity.
I have the other people come. You said somebody else had the meeting at 4, didn't you say?
I thought there was another meeting scheduled here, but
It broke. Okay, go ahead. They made a mistake. Okay, so we get to hear from you. Huh? Yeah. If we could have about, if you could limit it to 15 minutes.
Can we get just the map of the north? All right, but don't put it up yet. Let me start out by saying how much I appreciate what Sheriff Massey and Terry Norris said at the very beginning, that we are really all friends here. We are not in disagreement in terms of our commitments to people with mental illness and to those with developmental disabilities. And so what we are here to talk about is how do we move forward. Certainly there's a long tradition in mental health in Milledgeville, but also across the country, that has been primarily custodial. And this goes back really to the beginning of time, because the nature of the science of medicine and psychiatry limited our options to custodial care. And so we did what we could. But in the last 30 to 40, 50 years, the advances in psychiatry have been dramatic, and people are experiencing more independence and more autonomy than ever before. And so we hear the word today, recovery. And recovery was not a word that was associated with mental illness. Severe mental illness really had the same impact as being told that you had cancer or that your family member had cancer. It was not something that you anticipated beating or recovering from. And so recovery, the idea that someone with mental illness is not a dependent, is not someone that we look down on with paternalism and feel that they're somehow less of a citizen or less of a person. They are really one of us. They are our mothers and fathers. There are our own children. There are our brothers and sisters. And so the biggest shift in front of us really is in our own minds and our own attitudes as we think about where are we going and who are these people. And I think that recovery is something that we all need to know more about in order to fully understand and appreciate where we're going. Having said that, by way of introduction, what has happened most recently? This is a new department that is just over 18 months old. We're at our 19th month, and this department was born in crisis. The United States Department of Justice felt that the state of Georgia was in violation of the Constitution, violating the civil rights of individuals with these disabilities through inadequate treatment. To put a face on that, less than 3 months, 2.5 months prior to taking this position as commissioner, there had been a murder in our hospitals. One patient had murdered another while on one-to-one observation. Clearly, something broke down. Within weeks of taking this office, I was shown a picture of a patient who had been severely beaten by a staff member. When I asked, when did this happen? It took 3 days before this was discovered. there was a code of silence that allowed people to basically look the other way for 3 days until someone that I had sent down there asked, why is this half of this patient's face all battered and bruised? I carried that photo in a folder for the first 6 months in this office. I shared it with Governor Perdue. I asked that everyone who had been silent in this be terminated and that the individual responsible be arrested. I was told with a straight face by, at that time, a director in my department that it wasn't against the law in Georgia for a staff member to hit a patient. I was astounded, but my normal way of responding is to pause for a moment and ask, how is that? And I was told that because staff have to touch patients in the course of delivering hospital care, that if touching or anything like this could be considered battery, then it would lead to all kinds of things. And so there was a special exception for hospital workers that exempted them from charges of battery. All right? You can imagine how I felt. And after I paused for a minute and wondered, what do I even do with this? Where do I even go? I looked at this individual and I said, that may well be the case in Georgia. But I'm concerned that this patient has had his civil rights violated. And I would like to speak to the federal prosecutor right now. He left my office, and about 20 minutes later he returned, and he said, I have to correct myself, it's not against the law in Georgia, and the sheriff is on his way to arrest this individual. What would have happened had I not have asked for a federal prosecutor? I don't know. But what I saw was a system that had eroded over time, and a culture that had grown up that reminded me of really what is spoken in the end of Revelation in chapter 18, a description of Babylon and of the commodities that are traded and go in and out of her. And the last of those commodities in verse 13 is the souls of men. And I realized that we had a very big job in front of us. We had to change a culture and an attitude towards people. And so, yes, we had to bring in outside resources, just shy of 30-some specialists in all different disciplines, social work, nursing, psychiatry, psychology, and we dispersed them amongst the 7 hospitals. And yes, it's expensive. But I'll tell you, the state settled in that murder case for a sizable portion of what that contract is. So you will spend the money, it's just a matter of where you're going to spend it. Nonetheless, we found ourselves basically as a new department with a very real question as to whether we would even be able to exist as a department freely. The Department of Justice felt that really they should be taking over the situation because of the things that I've just spoken of. I just gave you a couple examples. In the first few months in my tenure, I dismissed 2 entire shifts in 2 different hospitals for this kind of negligence. We established a zero tolerance. I had people coming to me telling me that, well, on this shift, a couple folks are classified. At that time, I didn't know what classified meant. Okay? My response is that is very interesting and very irrelevant. And if necessary, I will testify myself at whatever level of hearing this goes to. Because what is at stake is a culture. We are involved in the lives of people, and we cannot compromise certain fundamental values. And we must have zero tolerance for these kinds of things. So when I hear that Central State was both the first and the last resort, that is a very frightening thought. because the Department of Justice, when they came the last time, delivered such a scathing review that basically the choice was mine or theirs. They deferred to me to allow us to close. So it has not been easy. It's not been simple. I wish that things fit into sound bites better, but they don't. What I would like to say here in the short time we have is that the settlement agreement is not the perfect and complete blueprint for anything and everything that we need in these areas. I stand with the sheriffs. I understand. I am the last person who wants to see someone with mental illness sitting in a jail. Now, in fairness, there are people in the jails who have diabetes and high blood pressure and many other things. And so having mental illness does not necessarily mean you need to be in a hospital. You are still responsible. Recovery means that you take full responsibility for your life, and so you may in fact need to be in jail. And you may need your diabetes and high blood pressure treated and whatever else. So there's a lot of detail here that we don't have time to go into. But let me just say that everyone with mental illness does not need to be in a hospital, wherever they may find themselves. But do we need to do more? We do. The settlement agreement is not the be-all and end-all. It is a minimum. It's a floor. It is, as Sheriff Massey said, a truce, a ceasefire. It is an agreement we have with the United States Department of Justice that at a minimum, we will do this much. Is it enough? Is it adequate? I don't know. We will have an annual review with the Department of Justice, and they will look and see, first, have we done it, and how adequate has it been? So it is very much a truce. There are many things that are not spoken to in the settlement agreement at all. Forensics, which we've heard a great deal about, which is very important. In fact, forensics is 60% of our psychiatric census in our hospitals, 60%. Only 40% of our psychiatric census is this civil patient that we talk about. That's of the psychiatric side. We have the largest portion of people in our facilities are really with developmental disabilities. They represent 45% of the total, 35% is forensic, and only about 20 to 22% are adult civil. So forensics was not spoken to. As Sheriff Massey said, a good deal of this settlement agreement does apply to developmental disabilities and to moving those individuals. And as others have testified, we do not have waivers for everyone in the community. There's a very large hill to climb there. We need a separate forensic solution. Children and adolescents is not spoken to in the settlement agreement. So the settlement agreement does not deliver you the perfect world. What it does do is it establishes a framework, a skeleton, and it begins to put the priorities in place that begin to allow us to move out. Now, there is a phenomenon of if you build it, they will come. And when you have a hospital there, you will default to it. And it takes away that pressure to do something else. And that, I think, we see in some of the numbers. If you look at the counties, the 7 counties or so that were the former catchment area for Central State proper, in the 6 months prior to closure, there were about 750 admissions in those 6 months. In the 6 months after closure, there were only 240-some people from those counties who went into the hospital. That tells me that, and I have felt this from being in our other hospitals and from having worked in one of them, that almost half of our admissions are not necessary. They don't meet actual medical requirement for hospitalization. They are admissions by default. Because someone is homeless, someone lacks food, they want a warm meal, they're cold, whatever. Or there's been an altercation. We often have the phenomenon of someone is discharged from the hospital, they go somewhere, they're back in a couple days, and when you question them, well, there was an argument over somebody drank my Coca-Cola at the group home. Part of recovery and part of progress is dealing with that. Someone drank your Coca-Cola, someone needs to resolve that there, not go back to the hospital. People go back to the hospital at the slightest altercation or tension in life because it's there. So our hospitals have served as our default, and they have allowed us to not deal with what we need in the community. And we have not attended to the hospitals well either. 27% of our hospital budget is maintenance and repair. Our newest buildings are 40 years old, with one exception, our forensic building in Milledgeville, which is still fully operational. Many of our buildings are much older. 27% of our hospital budget goes into maintenance and repair of falling down buildings. By their office park nature, they are inefficient in terms of staffing, and for many, many reasons, they are often found to be dangerous. After the Department of Justice left, we had a visit by the Joint Commission looking at, after one of the visits of the Joint Commission, of the Department of Justice, we had a visit by the Joint Commission that said that basically, said straight out, the Powell building needs to be razed to the ground. It's not possible to repair the physical plant to make this a modern psychiatric facility. So we have not, over time, we have not attended to that resource that we have looked at as both our first and our last resort. And we have allowed it to crumble down around us. And so now we are at this juncture. We have to move forward. We have to move forward in how we see people with disabilities, and we have to move forward in how we're going to deal with them, how we're going to provide services acutely in acute hospital settings or something similar, and how we're going to support their recovery over time with all the other natural supports that are necessary, supportive housing, supportive employment, and all the other things that you've heard about. That's my initial response. In 1 second, I'd like to show a map, if you can push the button and just show the northern region. Unfortunately, communications are what they are. You can't start talking to someone without telling them what it is you want to talk to them about. So we find ourselves talking about the hospital in Rome. Can we pull that up a little, or pull the screen down? There we go. All right, this is Region 1. Floyd County is over there in the red on the far left-hand side. What this map shows is the plan for resources to go into Region 1 to make it, to give it a continuum of care. What you see are 4 hospitals, the H's, one in Floyd County, one in Cobb, one in Hall County, and one to the north in Whitfield. 2 of these hospitals in Cobb County and in Hall County are already certified as emergency receiving facilities for mental health. That means they already have bed space, they already have all the legal authority and certifications to begin taking patients tomorrow. What you see in the CSU boxes, one in Hall County, one in Cobb County, one in Polk, one in Floyd, and one again in Whitfield. These are those 16-bed units that Ms. Harvey spoke to us about, that River Edge manages a few of. I don't think she was completely thorough in explaining all the services that River Edge provides, but they're managing 3 of these down in that Bibb, Baldwin, Dublin area. So between those CSUs and those hospitals, we have far more acute capacity than we currently have at Rome. Rome's newest buildings were from the mid-'70s, and some of the buildings go back to World War II, where it was previously a tuberculin facility. The A's are ACT teams, new for Cobb County, Floyd County, and again Hall County. And a crisis management team case management team is proposed for Walker to help support Lookout Mountain. This is the community plan to support, not just to replace beds in Rome, not just to replace them, but to provide support for people to be treated closer to home. This would allow sheriffs from the South Carolina line to go straight to Gainesville, to Hall County. It would allow sheriffs from Cherokee and Bartow and others to go to Cobb or to Floyd, and it would allow people in the far north to be served in Whitfield. So but it's not just a reduction or convenience. I've never heard, the sheriffs have never implied that they want more convenience. They always reiterate that they're there to do the job and transport and serve people. This is so that people are served closer to their homes, so that their transitions are smoother, and so that their recovery is more successful. The June 30th date is the date at which all this is in place. And then after that date, we will resolve what happens to the Rome Hospital. And that's what I wanted to share.
Representative Manning.
You said in the settlement agreement that the children and adolescents are not spoken to. So what's happening to all the kids with mental illness? And I'm talking about those children that are emotionally disturbed, and the ones I'm particularly interested in are the ones in Cobb County, the Devereaux Center, and also Inner Harbor, and the other 6 residential units that serve those populations. Because I've got a lot of heartburn over that.
Well, you're speaking to residential care for children and adolescents. That's one component in the continuum of care for children and adolescents. Most of the child population has moved to Medicaid or is part of the managed Medicaid services. We are asking ourselves questions about what's happening there. I've had meetings now, and we have commitments to meet regularly between myself, Commissioner Cook, and Commissioner Reese to discuss just other issues as well, but this in particular. And so David Cook and I have actually met together with many of our staff to look at the Devereaux situation, and we are continuing to see what the issues are there. Devereaux is a national company with operations in 11 states. They're headquartered in Pennsylvania. I don't believe they have any board members in Georgia.
Yes, sir, they do.
They have one, I believe.
They have on the national board. I'm not sure, but on the local board, they have several because they all call me.
Okay, well, I was told by the executive director that they don't have a local board, that they have one national board out of Pennsylvania.
Well, I can give you some names after the meeting,
okay.
But if I might, sir, could you possibly then either have one of your staff or yourself or somebody give me a update on what meetings are taking place and what actions being taken? Because I was under the impression that these kids, 100 of them with severe emotional disturbance, were being practically put out on the street, and they're not the Medicaid population.
Sure.
Yes, sir.
Sure.
Do I have any other questions? Thank you for coming. And I think one of the things that we've been most concerned about, I know when I drive to the Capitol or coming back from down Cortland, I see so many homeless people in Atlanta who have had mental ill problems, and we just don't want this to happen to anybody, to be moved out of a hospital and ended up living on the street. We want to because we have an obligation to take care of. It's a disease just like anything else, and we want to make sure that they're taken care of. And so I think Terry Norris said, we all want the best for everybody, and we're just trying to sit here and work out and see what's the best thing for people who are suffering from mental illness. And thank you so much for coming. And we'll continue this discussion. I think they're going to have a legislative behavioral health caucus meeting later on next week, and legislators will find out about that. Thank you.